This conference will now be recorded.
So today we are going to see the introductory lecture for this Mrcog part 3. So how you are going to start preparing for part 3. This is the basic motto of this lecture, how you are going to start. Okay, it is not for the mostly people who are already studying, but this is just to give insight regarding how you start preparing for part 3. Okay, so this is a majorly it is an introductory class. So myself, Dr. Mrudula and Dr. Jyoti, we will be taking this introductory class today. So first of all, I would like to congratulate all of you who have passed your part 2, and I think it's indeed a very great achievement, because what I think is part 2 is always the most difficult part of this Mrcog journey. And you have finished this part 2, you have passed part 2, conquered part 2, means you are definitely, your knowledge is complete. Now just you have to show this knowledge in your practical or in your applied aspect to get your degree, and just you are a small step away from part 3. And mind well, this part 3 is not a difficult exam. It's definitely, if you can pass part 2, definitely you can pass part 3 in one go only. There is nothing difficult about part 3. Only thing it requires proper preparation. The preparation you are doing for part 3 is totally different from that what you will require to do for part 3. That is the most thing. And once you get the knack of that preparation, you are definitely going to do this and you will be having this degree. So basically, the quote here is, your mind must arrive at your destination before your life does. Remember well, so you should, by your mind, you should reach this Royal College. Okay, you should be in your Royal College building taking the degree. Okay, you should daily have this dream, so that in your sleep, so definitely, and you should work it for that, and definitely you will be there for your Mrcog membership ceremony. Okay, so daily please vision this dream, and definitely you will be there. So now, who are eligible for part 3? Once you have passed part 2 and you have all these small specific requirements which are completed, then you are eligible candidate for part 3. So all of you have passed part 2, so the first part is over. Second part is, you should have this qualification, basic medical qualification. Okay, that is, in India you can call it as MBBS or other any basic medical qualification. It should be at least for 4 years. So you should hold this medical qualification for at least 4 years, and out of that, 3 years is after your internship. Okay, so 3 years after your internship, and it should be a total of 4 years after your basic medical qualification. Then you should attempt your part 3 exam within 7 years of passing part 2. So that is again one requirement. Who has done it before 7 years, I think nobody will be there. But again, if you have done it 7 years back, then you have to do it again. I think though nobody will be here like doing that. And another thing is, there are only 4 attempts, maximum 4 attempts for passing this part 3 exam. If you can't pass in 4 attempts, then you have to give part 2 exam again. But mind well, if you prepare well, you know you never require these 4 attempts. Okay, you are going to go in one go. Then another thing is this assessment of training. Okay, so AOT, previously this requirement was for part 2 only. So some of the people must be having this AOT completed before part 2. But if you don't have this AOT completed before, just you have to complete this AOT. You have to send this assessment of training form with your experience certificate and all your degree and all the certificates, and you get this your training approved. Okay, so that is the thing that you should do before your part 3. So I think majority people will not have this AOT done. So now just please be behind this AOT and get your AOT completed. Now, what is the format of this part 3 Mrcog exam? So it is a practical or OSCE exam. Okay, so that is, it is a clinical assessment of your knowledge, skills, attitudes, and competencies. And here, each and every word is important. So knowledge, yes, they have already tested your knowledge in your part 2. So it is the knowledge part will be somewhat lesser in this part 3 exam, but what they are going to assess more is your skills, your attitudes, and your competencies, okay, regarding a better clinician. And definitely, if you prepare for this part 3 exam, whether you pass, whether you fail, whether you go to UK for your further training or for the practice, it is totally a different thing. But definitely, you will become a much better clinician once you prepare for this part 3. That is a guaranteed this thing. You will get that attitude, you will get that. How to behave with patient, how to talk with patient. So all these things you are going to learn a totally new perspective while you are preparing for part 3. So this is most important part of taking this part 3 examination. Okay. And then yes, passing part 3, it is a gateway to go to UK for further training, subspecialty training, or whether you want to go in the NHS system. This is a required basic degree to enter in the OBG specialty in UK. So how the exam is exactly conducted. So on the exam day, what you are going to have is there are 14 tasks. So it is known as 14 stations also. So there will be 14 stations, one after the other. Okay. And each task will be based on one module. The modules which are given in core curriculum, which were you prepared for part 2 also. So each task or each station will be based on the one module. So there will be total 14 module and 14 stations. Each task or each station will be for 10 minutes. Outside cubicle, see here, you can see this white paper is there. So outside, so these are the cubicles. See, you can see there are very small cubicles will be there. Hardly 86 by 6 feet cubicles are there. Okay, for each candidate. So just you have to keep on rotating. Okay, so outside this cubicle, can you see this white paper? So on this paper, your task instructions will be printed. Your station instructions will be there. You will be given 2 minutes outside the cubicle, and after that there will be 10 minutes inside the cubicle. In the 10 minutes you have to complete your station. So basically it is the race against the time. You have to complete your station in 10 minutes. So total for one station you will have 12 minutes, but you can't go before 2 minutes inside. So just after 2 minutes only you have to go inside. So outside the 2 minutes you have to think what you are going to cover in the next 10 minutes. So total exam time, there will be 12 minutes for each station into 14 stations. So it is a 168-minute exam once it starts. There will be no break. There will be no rest. If you want to take a break, if you want to take this thing, anything, even for water also or something like that, it is on the you have to compromise your own time from the stations. Okay, so you have to prepare for that also. That is also a major thing. Remember, well, you have to continuously be attentive for 168 minutes and you will be talking for 168 minutes. Okay, so this is the one thing that you have to prepare also, because that is also a big deal actually. And then definitely after 168 minutes, it is your the thing, that is your future will be decided whether you are pass or fail. So it is a total play of 168 minutes, remember well, on the exam day. And for those 168 minutes you have to prepare very hard. Okay, now the time which is required, so see here, you can see, just I have done it enlarged thing. So you can see these are very small cubicles. There will be hardly one or two chair, one table will be there inside the cubicle, and you can see they are very nearby cubicle, so you can just listen the sounds from other cubicle to you also. Okay, so you have to concentrate with all this noise outside going on, and there will be bell ringing every 10 minutes and 2 minutes. Okay, so you should adapt to such a thing that you have to talk in that noise. You have to keep your ears to that bell, and you have to manage your those 168 minutes. So this is a basically what will be your exam day. Okay, so now for this, for those 168 minutes, how you are going to prepare in the coming months, because we don't know when the exam will be there, right? So right now amidst this all uncertainties with this corona, already the May exam was postponed, already the November exam also, it was only for UK candidates, but that is also postponed, and now they are telling that they are going to conduct the May exam. So again, how many bookings will be there, how many seats they will open for May exam, or everything is uncertain right now. So we don't know when the next exam is going to happen. Most probably it will be in the May, but how many people, how many seats will be there, how many people will get booking, so we don't know. And with this uncertainties only, you have to start your practicing, and you have to prepare for your part 3. But yes, there is no other alternative that we can do, correct? So now what are the modules? So each station will be based on one of these modules. And mind well, every every module will have one station. Okay, so just you can't do anything. Okay, I will keep something for option. No, nothing. You have to do everything. You have to complete all the modules. So the first module will be teaching and research. So there will be some simulated training tasks. So I will come to that later. So each one task from all these 14 modules: teaching core surgical skills, post-operative care, antenatal care, maternal medicine, management of labor will be different, management of delivery will be different, postpartum problems, subfertility, SRH, gynecology, early pregnancy, urogynec, and oncology. So all these modules will have one station each, and each station they are going to assess you on these following domains. Okay, so these are the 5 domains that you should be aware of, that they are going to judge you on this domain, and finally the result card will be there depending upon the domains only. So they will tell you in your result, like you can see in your part 2 result, they have given you whether you have passed, whether you have reached the expected standards in a part 1 is paper 1 SBA, paper 1 EMQ. So similarly, in the part 3 result, they are going to give you result on the based on this domain. So they are going to tell you in your result whether you have reached expected standards in concerned module. So patient safety, yes, reach expected standard. It is not necessary to pass all modules. It is not necessary to pass all modules, remember well. But you should, your overall aggregate should be up to the pass marks. So it is better to pass all modules only. Okay. So there are total 5 modules. One is patient safety. Second is communication with patients and their relatives. Third is communication with colleagues. Fourth is information gathering. And fifth is applied clinical knowledge. And remember well, these all modules are not different to each other or alien to each other, but they are totally interrelated domains. So each 14 tasks, they are going to assess 3 to 4 domains. Okay, they will give you which domain they are going to assess. So they, outside the cubicle where they will paste the picture, in that they are going to give you which domain they are going to assess. So these 3 to 4 domains for each task they are going to assess. And remember, as I told you, all domains are interlinked to each other. Like communicating with patients, it is again linked with applied knowledge, or communicating with colleagues also, it is like because of for the patient safety only. So they are interlinked domains. And so for that matter, you should not think differently for each domain, but you should think it as a task, and you should include all your domains in that task. So what are the types of tasks? So types of tasks, there are 3 types of tasks you are going to get, or 3 types of stations you are going to get. So one is simulated patient task, which is also known as SPT. Okay, so it is a simulated patient task. Then another will be simulated colleague task. So there will be a role player, which will be, so it will be mostly like a teaching station. And third is a structured discussion. So structured discussion is only thing the examiner and you will be there, and it is like a mostly like which is in our viva in your hospital in our country or other countries. What are these OSCE stations? So it is basically the question and answers with the examiner, the structured discussion. Previously, the total number of tasks or stations, they were 14, so they were divided usually into 1 or 2 teaching stations, 7 or 8 SPTs, or 3 to 4 structured discussions. But now what they are going to what that telling is there are 7 plus 7. So there will be 7 SPTs and 7 structure discussion. Even for our exams also, we have given in November 19th. So in for our exams, it was the last exam which was conducted by RCOG. In that exam also, what they have told, there will be 7 7, but finally we had almost 9 tasks of SPTs and 5 tasks of structure discussion, but still they are telling that they are going to divide it equally. So you may get 7 structure discussion and 7 SPTs. So SPTs means it will be either teaching or role player task. Okay. So what are the simulated patient or colleague tasks? So it involves the candidate. That candidate has to interact with an actor, or which is called as role player also. So this role player is fully trained and they have a script. Okay. So they know exactly how to answer the questions and how to tell and where to stop you. If you are going haywards, they will stop you and they will try to bring you on the track. Remember that these role players, they are there to pass you, they are not there to fail you. Okay, only thing you should know how to extract information from them. That is most important part in this simulated patient's task. So the actor or role player, she will know all the relevant details pertaining to the case, and she will have some scripted questions to prompt. So as I told you, if you are going out of your track, she will try to ask some question relevant to that, and she will try to bring you on the track. So they are there to pass you. And one thing is there, these tasks may involve lay examiners. Lay examiners means they are not doctors. Okay, they are not doctors, but they are other than, they can be of any other professions. Okay, or they can just housewives. So they can be anyone. These lay examiners can be anyone, but these lay examiners are there to assess you, your communication skills, your overall attitude towards the patient. So they will basically judge how you are behaving with that role player. Okay. So, and these lay examiner stations, they carry the maximum marks, remember well. So out of this 7 to 8 SPTs, there will be 3 lay examiner, minimum three to four lay examiner stations will be there. So see in this cubicle, as I told you, so there you have to see once you enter the cubicle. The trick for this is, once you enter the cubicle, you have to see how many people are there. Okay. See, for structure discussion, you are the candidate and one examiner. That is the only people will be there in that cubicle. Okay, there will be only two people for the structure discussion. For SPT, like any teaching station or any role player task, there will be two people seated inside. One will be the examiner and one will be the role player. And if you find 3 people are there, you should know that it is a SPT, and there you have to be very careful. For all tasks for that matter, you have to be very careful how you are talking with role player. But here in this, whenever there are 3 people inside the cubicle, you have to be very attentive how you are talking with the patient, how is your non-verbal communication. So here all these things matter, whether you are using any medical language, okay, whether you are using any medical words or whether you are talking in layman's wordings. Okay, so all these things matter whenever these tasks are lay examiner tasks. So any SPT, so what is the nature? What can be the nature of this SPT? So this SPT, they can come as a clinical situation. Okay, from any module, they can come as a clinical scenario where you have to take history, explain the diagnosis, and formulate the management plan. Like you can say for ectopic pregnancy, like you can say for PMS, like you can say for HMB or fibroids. Okay, so here you have to take the history, explain the diagnosis to that role player, and formulate her management plan. Another task can be either interpretation of results, which may include the images, charts, blood investigation. So, like ultrasound images can be there, MRI, CT scanning images can be there, some charts like urodynamics charts, CTG can be there. Sometimes the post-operative management chart, which is called as mute chart, early warning score charts, they can be given. Blood investigations can be given, and you have to interpret this investigation and explain the diagnosis to the patient. Histopathology report can be given. Okay, so you should know all these things also. Then there can be consent taking tasks. So in that case, you have to take a consent from that role player for a any procedure like you say hysterectomy, vaginal hysterectomy, diagnostic laparoscopy, okay, any instrumental vaginal delivery. So there can be a consent taking task can be there. Sometimes post-operative complication counseling, so post-operative patient can be given and you have to explain the complication and further management to her. Then breaking bad news, usually there will be definitely one or two breaking bad news stations will be there, and these breaking bad news stations will be most commonly involve oncology, where you have to reveal the diagnosis of cancer or sometimes anomalous babies, okay, or sometimes IUFD, okay. So these will be the breaking bad news station. Here you have to use your all non-verbal communication. You have to give patient the time to accept her condition. You have to see that you have to be very empathetic to the patient. So all these things it will be seen, okay, and they will carry the marks. Also like debriefing like any post-operative complication like hysterectomy, post peripartum hysterectomy will be done, or sometime any major complications like bowel injury, colostomy, or uh, debriefing after the IUFD or third degree, fourth degree perineal tear. So in that case, you have to debrief the patient or the relatives, and this will be again a major of a counseling station. Again, sometimes angry patient or relative. So because of some complications, the patient might be angry. So in that case, you have to counsel the patient properly. You have to see whether the patient wants to make a complaint. You have to see that you have to counsel her appropriately, the patient or her relative. And so all these things carry marks. And here, so here you can see the part is only one and two part is regarding your applied, more of the applied knowledge, and rather all these parts is mostly dependent on your communication skills, okay. So this thing should be you have to develop. So this preparation is that's why I'm telling this preparation is totally different from what you have prepared. You have read all your guidelines, you have read all your this thing strategies and this thing for RCOG e-learning for your part 2, but now the reading will be less and practicing will be more for part 3. Now coming to the simulated colleague task. So simulated colleague task, it is mostly teaching. So you are junior. They see at your MRCOG part 3. Once you are MRCOG, you are equivalent to the ST5. Okay. So it is a ST5 level in the UK training system. So you will get the ST5 level. So at ST5 level, you have to teach your juniors regarding the some procedure like foundation year trainee or ST1, ST2, ST3. These people you have to teach some procedure, simple things like entry, laparoscopy entry techniques, episiotomy, or diagnostic hysteroscopy, CTGs, urodynamics. So all these things there will be teaching station. You have to teach regarding consent taking, charts, forms writing like discharge cards, prescriptions, then pre-op, post-operative notes. So all these things you have to teach. Then giving feedback. If they have done any mistakes, then you have to give them feedback, okay? And undermining and bullying. So see, undermining and bullying is a major thing that is seen very seriously, that is looked at very seriously in this NHS system. So you have to see if your colleague is undermined or getting bullied. So you have to identify it. That is the first thing. And there are specific things or specific pathways. While if that colleague, your junior colleague, is getting undermined or bullied, you have to help her or help him, and you have to tell the appropriate procedure to counteract this undermining and bullying. So undermining and bullying is also an important thing of this. So you have to identify whether your colleague is getting undermined or bullied. So here the role player is going to give you some instruction, some things, some clues that she is getting undermined or bullied, and you have to identify those clues, and depending upon that you have to act upon. So this is also again a major thing of this simulated colleague task, okay, or the teaching stations. Then structured discussion. Here the candidate is directly interact with the clinical examiner. So examiner here will have detailed instruction about the task and list of questions. So they can use to prompt the candidate or move the task ahead. so that candidate does not run out of time. So here the examiner is asking you question, you have to give the answers, detailed answers regarding pertaining to those tasks. Sometimes it will be a evolving discussion. So sometimes just examiner will ask one question and you have to talk for all the 10 minutes, or sometimes it will be a evolving discussion. So first we'll take how you are going to come to a diagnosis. Then he will ask the necessary investigations and then the management plan. So it can be evolving task also. Or sometimes the examiner will give you some CTG paper or urodynamics, and then he will ask the diagnosis, and then he will ask how you are going to proceed further for this thing. Okay. So this can be a structured discussion task. So here your theoretical knowledge should be very perfect. So in structured discussion task, what are the anticipated tasks or stations you can get is, so case scenario discussion. As I told you, you will get a one case scenario and examiner will going to ask the questions on those, or interpretation of charts or investigations. Labor ward prioritization. So you will get 8 or 9 patients and they will ask you to prioritize this labor room. Okay. That is also a big thing. You have to know how to do it. Then pre-operative rounds, post-operative rounds, theater list prioritization. So these are some difficult stations from this structured discussions. So for all this, how you are going to practice? So first thing what you have to see is you have to make a habit that you should finish your task in 10 minutes. Because see, there are topics you may talk on that topic for hours on. Okay. But it is not the thing. You have to show your knowledge to the examiner in the 10 minutes. So that is a major thing that you have to practice. So you have to finish your task in 10 minutes. So for that, you should finish your task in 9 minutes when you are practicing. And this is very difficult initially. This is very, very, very difficult initially to finish your task in 10 minutes. But, so that is a major practice that you should develop to finish your task. So whatever you have, that information you have to concise it and you have to deliver to that role player so that examiner will understand that you know everything regarding that station. Okay. So that is a major task that you should get to practice. Polish your communication skill. You should be a good listener. You have to develop a habit of listening to the role player. Okay. Because role player will be always there to give you clues. Okay. If you are going also out of track, as I told you, definitely role player is there who will bring you on the track. But if you are the one who is doing all the talking and you are not giving time to talk to the you are not giving role player time to talk, then definitely you are not going to get those clues and you may fail that station. Then you should understand the exact nature of the task. So you should know exactly what is expected from this task, whether it is a breaking bad news task. So sometimes the counseling is more important than your applied knowledge. Okay. In some tasks, counseling is more important than your theoretical knowledge. So you should know exactly where it is the important, where to deliver your knowledge is more important, or where here the communication is more important. So you should know the exact nature of the task. And definitely for SPTs, for role player task, you have to use the layman language. Okay. You have to use the layman language. You should not use any medical jargons. Okay. You should not use. So see, to simply tell that abdomen. So you should not use the word abdomen, but you should call it as tummy. Okay, when you are going to do the SPT task, you should not use the word uterus, but instead of that, you should use the word womb. Then you should not use the word cervix, but you should use the word neck of the womb. So you should use all this layman language, okay, and avoid all the medical jargons. Now, how you're going to get this? So how you should know that these are the words which are used in the UK for this layman's language. So for that, there are the PILs, that is patient information leaflets. So I will tell you that how you are going to read this layman's, where you are going to find these words. Like when you want to ask any urinary complaints, you have to ask regarding how is your water work. Okay. So how is your water work means it is whether you have any urinary complaints. So you should know these words. So regarding the study material which you are going to use for this part 3. So now I will tell you that now you have to give a second importance to your guidelines, to your GTGs and NICE guidelines and all those things. So first thing is the books. So books, I will tell you which books to use. There are only 4 books that you have to follow. There are no 10 or 15 books. There are only 4 books that you have to follow. Then patient information leaflets, which is called as pills. Okay, so these pills form the major chunk of your reading material. This patient information leaflets, these are from RCOG, these are from NICE, or whenever for any disease there is no PIL by RCOG or NICE, you have to see for an individual trust hospital PIL. Okay, patient information leaflet. You have to read this patient information leaflet to know how to counsel the patient. Okay, how to establish communication with the patient, how to counsel the patient. So for these things, you have to read the pills. So see, wherever the GTGs are available, like breach, like APH, placenta previa, and then regarding OHHS, regarding the, so wherever the GTGs are available, there are RCOG pills are available. Okay, whenever the GTGs are not available, where there are NICE guidelines, the NICE pills are available. And there are some topics for there are no RCOG guidelines, like you can say amniotic fluid embolism. So there is no RCOG guideline for that. For fibroid, you can say there is no RCOG guideline for that. So for that, there are some pills. Okay, so which are developed by their own hospitals. So you have to search for those pills, and it is available. Everything is available on Google. You have to just type. You should know how to search. That is the only thing which is required for this. So see, fibroid. If you type fibroid NHS pill, fibroid NHS patient information leaflet, you are going to get at least 10 information leaflets of different hospital. Now only thing, you have to select one or two from that. There is no need to read those all 10 pills, but you can just read one or two, like Marfan syndrome in pregnancy. It is a very common station which is asked in the exam. Okay, so Marfan syndrome in pregnancy, there is no RCOG pill for that. So for that, there is no NICE pill also for that. So you have to type that in your Google. You have to type Marfan syndrome in pregnancy NHS patient information leaflet. You are going to get at least 7-8 pills. So you have to select one or two from that and read it from that. That is the thing what you are going to read. So this is basically, this is a mostly online thing that you are going to get the material here for part 3. It is not a particular material that is there ready-made available for you and you are going to read it from that. It is not like that. So for any condition, you have to first find out patient information leaflet regarding that disease, and you have to read that and you have to follow that pill. Okay, so that is the thing that you should do. Then recalls. Recalls are there. So many files are available for recalls, and mind well, recall stations are coming in each exam. At least 4 or 5 stations will be recall stations. So you have to do the recalls. And for structure discussion and for any management plans, your theory material is required and guidelines are required. And there are strategy videos of special tasks. So now remember that there are not many videos by strategy. There are hardly 13 or 14 videos by strategy, and they are freely available in all the groups. Okay, they're freely available in so many groups. So no need to buy the strategy videos for that, but you should listen to those videos. So for the first few days, try to listen to all these videos of these different stations. So you will get the idea how you have to start the station and how you are going to finish it in 10 minutes. So this is the important thing that you should use here. More than reading, it is the listening and talking. It is the required for this part 3. Remember well. So these are the 4 books which are most important for this part 3. You should complete all these 4 books. There is not a big, these are not 1,000 pages books. These are very small books actually. Every book has hardly 20 or 30 tasks. So this is a second book. You can see it is Essential Revision Guide. It is a book which RCOG recommends. Okay, which RCOG recommends for part 3. It has got 14 stations. So it has got different every station on each module. And they here that Lisa Joel and Edmund Neal, they have given a beautiful approach how to go about that station. Okay. Then again, this is the OSP or Oxford revision task. So it is also a very important book. This is the best book I think I will tell you regarding how to start your preparation. Okay, this is the basic book where you have to start your preparation, because it is again module wise, and here they have given very beautifully how to deal with the task. Okay, so what is the expected from a given task? So they have given a proper keys regarding those tasks in this book, in these OST books. Then this get through book. See, this get through book, it is important. Why? Because they have given all these difficult stations, how to go about the difficult station like audits, appraisals. Okay, there are some stations in your this thing regarding teaching or clinical governance, like audit station, appraisal of leaflet, appraisal of a study. So these stations are beautifully given in this get through book. So this and again this layman's terms, they are given also beautifully in this get through book. And this fourth book, that is Hollingworth, Tony Hollingworth book, this is also a very good book. This is basically they have given good task in this book for your practicing. Okay, so all these four books you should follow. I think there is no other book that you should follow for this part 3. So you have to be thorough with all these four books, and the task of this all four books. Okay, so this is your basic study material for the part 3. Then next thing, as I told you, PILs, that is patient information leaflets. So I have given these three different. So how you are going to find out? So first you have to see for a RCOG pill. If there is RCOG pill is available, no need to search for any other patient information leaflet. You have to read this RCOG pill. So here you can see this placenta previa, placenta accreta. So whenever the guidelines comes, they do this, print this patient information leaflet also along with the guideline. Okay, so you have to see for this pill and you have to search for. So whenever there is GTG is available, there will be pill there definitely. So for this you have to, so whenever the RCOG pills are available, you have to read those pills. So please I get one folder of all these RCOG pills together, so you can read those things. Then according to nice guidelines, so whenever there are nice guideline available, I can see, you can see here it is a diabetes in pregnancy. So whenever there is a nice guideline is available, you are going to get a nice public patient information leaflet. And the third thing, whenever you are not having any guideline for that topic, then you have to search for a different pill. So just as I told you, you have to type the topic, you have to type NHS and patient information leaflet in Google, and you are going to get so many patient information leaflets from this NHS Trust hospitals. And you have to select. So see, for fibroids, there are at least 10 or 12 pills are there. You have to select one or two from them. You have to read from them, and you have to decide which you are going to follow. So this is regarding the pills. So once you get all your material ready, how you are going to start the preparation? So first thing first is find a study partner. If you don't have a study partner for part 2, it is okay. You can do it all alone. But part 3 you can't do on your own, because you need a study partner to practice the stations. Okay, because there should be someone who should be listening to you, who should be correcting you. Yes, if you don't find a study partner, it's not that you cannot do it, because sometimes I can understand it is very difficult to find a study partner. So in that case also, what you have to do is you have to find out someone from your family, like your husband, your wife, your kids. Okay, and you have to practice with them. Basically this is regarding the talking practice. You have to talk and talk. Okay, so that is the thing that you have to practice. If you don't find anyone, you have to practice in front of the mirror. But yes, if you are lucky enough to find a study partner or a group as such, okay, try to do a group of 3 to 4 people. Remember that don't do group more than 4 or 5 people. In that case, you are not going to get practice too much. Okay, so here basically you should practice one station, another people will become role player, and third person will become the examiner who will give you feedback. Okay, because sometimes what happens, if you're only two, what happens is one person will act as role player, one person will act as candidate, and in that case you may miss certain points in the feedback. But if you have three, it's the ideal situation is three. Okay, so one is the examiner, one is the role player, and one is the candidate. It is the ideal situation actually to practice, but I know it's not possible everywhere and anywhere. So if you are lucky enough to find three people to study, it's a very good thing. You are in ideal situation. But if you don't have such, at least find one study partner with whom you can practice. Okay, it is not that you should be at the same location. You can do it on phone, you can do it on Facebook, you can do it on this thing, Telegram calls, WhatsApp call, whatever it is. Okay, but whatever you are doing, you try to record it. Okay, you should listen to it back. That is the most important thing. And I will tell you to start module wise. So do your station module wise. Start one module, complete all the syllabus from that module, and go to the next module. So by that you will not skip any station from that module. Okay, you will get so many sites, you will get syllabus of this. So how many there are around 300 to 400 stations that you have to practice. Okay, there will be almost 300 to 400 stations that you have to practice. So you should be doing all these things. Practice daily. Remember that whatever is there, whenever is the exam, we don't, because we don't know when is the exam. So now you don't have any target ki I have to do daily 5 station, daily 6 stations. So no, but now at least what is in your hand, at least practice daily 1 or 2 station. That is in your hand. Okay, if you can practice 1 station daily also, I think it will be enough for May exam. So but it is the consistency is very important. Your habit of talking should be there. It should not go. Okay, because if you forget this talking habit, then again it is going to take very long time to keep come again on back on the track. Okay, now first, whenever in the morning, you have to decide what stations you are going to do in that day. Whatever 1, 2, 3, whatever is there, what is your target, whatever is your target, depending upon your other schedule, you have to decide which stations you are going to do in that day. Read the PIL regarding that. Read the patient information leaflets of that station. Read the important theory points. Now, whether you should read all the guidelines. It is again question so many people will ask whether all the guidelines are required. So now it is not required that you should read all the guidelines, but yes, summaries you should be knowing, because whenever you have to tell the management part, you should know the what are the major recommendations. So basically the summaries which are given in the guideline, those are more important. And for structured discussion, you should be very thorough with your theory. Okay, so that is the thing. For some SPTs, if you don't know some points in theory also, you can skip it off. You can just give some excuse. I will ask my senior. I don't know right now. You can say for that. Okay. But you can't say it for structured discussion. So for structured discussion, you should know your theory part. Then listen to the videos and recording of that station. So whenever you have decided I will do a station, like see, you will do some station regarding urogynecology, like stress incontinence or urge incontinence, you are going to do that station. So listen to the videos which are available. There is so many material which is available in the groups. Till now you must be also aware of, there is a very good drive, Google Drive by Dr. Mohammed. This contains a lot of information, and I think that is a complete drive that is enough to pass part 3. Okay, so it contains all the information, all the recalls, all the PILs also for that matter, I should tell you. So just listen to the videos which are available. There are so many free groups are there. There are so many free sessions till now has been happened by different mentors. And listen to these videos, because right now you have ample of time. Okay, so try to listen to the videos and recordings of the stations on and off, so that you will know what are the lagging points, what are the things, and what should I do to complete that station. Write your master key of that station in your notes. So if you are going to do this incontinence station, try to listen to that video before you start talking. Okay, before you start preparing. Okay, so that you will get an idea how you are going to go about that station. Write your master key in your notes, because again I will tell you, in the last month Okay, right now you can listen to the videos, you can record your own voice, whatever you can do right now, you can listen. But in the last month, you are not in the this thing mood to listen to your own voice. I will tell you, you're not going to listen to the recordings also. So in that case, whatever is going to come to your help is your notes. Okay, so it is write the master key of that station in your note, whatever station you are going to prepare, because this is going to help you in your last 15 days. Okay, then practice with your study partner like you will perform in the exam. So keep a time. You have to finish that station in the 10 minutes. So it is like in the exam condition, you have to practice. You have to record that station. After completing it, listen to that recording, take feedback from your study partner. You also can give the feedback. You also can understand so many things once you listen to your own voice. Okay, I'm just going to give you example. Okay, from our own practice. I will rather tell you. So you can just get, you see, whenever you are in the initial stages of your preparation, the station you have recorded in your initial stage of preparation, and then after of 2 or 3 months preparation, there will be heaven and hell difference in between two recording, and you will not feel to listen to your voice when you have done it first time. Okay, so uh, but still you have to record it, because you should know your drawbacks. Basically, you should know where you are going wrong, and for that you have to listen to that, and there then and there only you have to correct it yourself. Okay, so I'm giving these two examples, remember. So these are from our practice. We have started practicing somewhat seriously in June. Okay, me and Dr. Jyoti were study partners. We have started recording in June, and I have still now we have at least 300 stations recorded in our own voice. Okay, we used to do daily two stations. One, I was acting as a candidate, and she used to act in one station, and inversely we used to be role players. Okay, so just I will show you these two differences and you will understand. I'm laughing today morning when I was listening to this. Just go. I'm not going to show you all the 10 minutes, but just for example. Oh, sorry. Okay, so this was my recording in June. Okay, you can see I was fumbling initially. I couldn't explain what is molar pregnancy. Okay, in spite of preparing that station, in spite of reading all the information, I couldn't talk. Okay, in initial stage, and then this was the station in the August end which we have done. So it was actually a difficult station. One that is monochorionic twin pregnancy with one anomalous baby. So see, I will not tell that this is also a perfect station, but still there was a lot of improvement, and it comes with practice only. It is not going to come with your theory knowledge, okay? Because you must be also laughing today because yes, she can't tell regarding what is malar pregnancy also, but yes, this happens. You couldn't explain also. So that thing you should do, and you should know all your drawbacks, okay? So now you can see in the 2 months with practice what can happen.
Excuse me, Dr. Mrudula.
Yes, 1 minute.
Yeah, I just wanted to confirm whether the candidates are able to listen to the recording. I am not.
Oh, you couldn't listen to the recording? Hello?
Yeah. I
No,
just
no, the
want to
recording.
confirm the
Yes,
other candidates.
ma'am.
Yes.
No,
You
we
couldn't
can't
listen to the
listen.
recording?
We can't hear you, ma'am.
Yes, the
Oh,
recording
okay,
was
okay,
not
okay.
audible.
But I'm able. Oh, okay, 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 okay. One thing, I will try to do it. Otherwise, I will tell you. Then we have to go this 1 minute. Just can you listen? It's running.
No, ma'am.
Okay. So I
We
think there
can't
is
hear
some.
you.
So I think there is some problem with this. It is not actually I am able to listen here, but it's not going to you. I don't know. Okay, so forget it. Actually, it was the thing behind this was, see, there becomes it becomes lot of difference, heaven and hell difference in the 2 or 3 months only with practicing. Okay, so you can see what you can do in 2 or 3 months. So what the first recording was of molar pregnancy. It was a very simple station of complete mole pregnancy. You have to explain the histopathology report to the candidate, okay, to the role player. But even in introduction, I got fumbled. Then even during explaining, I got fumbled a lot. And even after reading the patient information leaflet and everything, I couldn't do better. And next station, it was a difficult station actually. It was a monochorionic twins with one anomalous baby. And even that also, it was not a perfect station. What we have done, it was not a perfect station. But yes, definitely there was a lot of difference, and your communication with the practice, it becomes fluent. I will tell you, I'm not a good one in communication, but still we can do it with 2 or 3 months practice. So definitely everyone can do it. So this is the thing, that only the consistent efforts are required. Okay. So how you're going to approach any station? First thing first, whenever you see one station, okay, even during your practice, you have to give like this only. You have to give 2 minutes for the reading, and you have to give 10 minutes for the station, and you have to follow the time very strictly. Okay, from the first time only, try to follow the time very strictly. Don't do for 13, 14, 15 minutes one station. Try to do it or finish it in 10 minutes only. So first you have to see what is the task, okay, whether it is a SPT, whether it is a structured discussion, whether it is a teaching station. See what is the station about. Then see the domains which will be assessed. So now see, you have to see all the domains, whether what is the domain. In all tasks, mostly the patient safety and applied clinical knowledge will be there in all tasks. Remember well. So all the tasks will contain these two domains. Now regarding other three domains, definitely if it is a structured discussion, it will involve communication with the colleagues, because here you have to interact with the examiner, and there will be communication with colleague. But in usually patient stimulated tasks, there can be all five domains also. So whenever there is information gathering, there will be definitely history taking and examination will be there. But remember well, if the information gathering is not there in the domains, okay, in your domains, then you don't have to you don't have to waste your time in the history taking. Okay, you don't have to waste your time. If the information gathering module is not there in your station, then you should not waste your time. So for that, it is very important to see the domains which are going to be assessed. In SPT, if there is a in simulated patient task, if the domain is there, communication with colleagues, then definitely you have to involve the MDT in that domain. Okay. See, like any task, like you can see a twin pregnancy. So for twin pregnancy, if you are doing SPT, And if there is a communication with colleague is involved, and if you don't include MDT. Now MDT here, what that MDT will be there? It is a neonatologist, anesthetist involvement should be there, midwife involvement should be there. So it is not only a medical staff, but it is non-medical staff also. It is non this things not other than doctors. You have to involve paramedical staff also in your MDT or your communication with communication with colleagues. So if you don't involve, if you don't utter those words, you are going to fail in that domain, in that station. Okay, if that station, if that domain is there in that station, and if you don't utter these words, you are going to, just for one sentence, you are going to fail in that whole domain, not station but whole domain, and definitely it is going to reflect in your marks also. So that is the one thing that you should remember. Then you have to note the name and age of the patient, because you have to call the patient with her name. Remember well, it is the most important point in your communication skills. You have to call the patient with her name. Write in the brief, you have to write in the brief in the outside 2 minutes only how you are going to approach with that station. Okay, so which points you can forget, that you should write there. Then inside the cubicle, as I told you, you have to see how many members are there. So you have to see whether it is a lay examiner is involved or not. If there is a lay examiner is involved, then you have to be very attentive towards the your communication, non-verbal communication, and any attitude, like any counseling. If the patient is crying, you have to wait. If you have to also be attentive of the non-verbal communication of that role player also. So you have to see what are the gestures that that role player is doing. You have to identify those things. If she is not maintaining eye to eye contact, so you have to see whether there is any sexual abuse. You have to identify any domestic violence in that case, whether she is keeping some information. So all these things are more important in those lay examiner station. Then have a quick look at the table. You have to see whatever there on the table, any props. That means if there are any instruments, like for the teaching station, if there is pelvis is kept, you have to use that pelvis. If the dummy baby is there, you have to use that dummy baby. If the varus needle is there, you have to use that. It is not that you have to just tell the theoretical point, but you have to use that prop. If the pessary is there and if the pessary teaching is there, you have to hold that pessary and you have to show it. So it is the most important thing. If any props are there on the table, like in Breaking Bad News station, sometimes there will be tissue papers will be there, glass of water will be there. So if it is a Breaking Bad News station, like anomalous baby, IUFD or cancer station, so if that tissue papers or glass of water is there, if you when you are disclose the diagnosis like cancer or IUFD, then the patient may start, role player may start crying. In that time, you just have to keep, you don't have to keep the silence, but you have to offer her tissues, you have to offer a glass of water there. Okay, and it carries marks. Remember well, so you have to look at the table. You should have a quick look at the table. You should know exactly what is there on the table, and whatever is there on the table, it has got some meaning and it carries some marks. That you have to remember well. Okay, whenever there is any prop is there on the table, even small kidney tray will be there. If there is hyperemesis station, okay, you have to see if the patient is starting like vomiting action, you have to give that kidney tray to the heart. Okay, so every prop has got some meaning on that table and you have to use that you have to remember. So you should have a quick look at the table, and then introduce yourself, greet the role player or examiner depending upon your task. Now if it is a SPT, okay, if it is a simulated patient task, the examiner will be sitting there. You don't have to introduce yourself to the examiner. Okay, there is no need that you should talk to the examiner. Actually, you should not talk to the examiner. You should not look at the examiner also in case of SPT. Remember that well. Okay. So for any SPTs or any role player task, the examiner is sitting in the side. You should not look at the examiner, but whatever you are getting mark, how you are interacting with that role player. So you have to greet and introduce to the role player and not to the examiner. Okay. Remember well. So you should not introduce yourself to the examiner, but you have to introduce yourself to that role player. And then start your station confidently and next 10 minutes are yours. Okay, and you have to wisely utilize those 10 minutes. So for any SPT, remember well, you should have your history taking for 3 to 3.5 minutes, then explaining the diagnosis for next 2 to 3 minutes, and your management will take next 3 to 4 minutes. Okay, so this is the usual time division that you should follow. Now coming to the domain wise, so I will just quickly go through all these domains and then we will try to do 2 stations, okay, so that you will understand how to go about the stations. So regarding information gathering domain, as I told you, you have to take the history and you have to do the examination, okay. So for that, first you have to introduce yourself and greet the role player, okay. So whatever it is, good morning, good evening, whatever, depending upon the time, and you have to introduce the yourself. So you have to decide one name, okay. So it should come at your spinal level, okay. So you can say whatever you have to decide how you're going to introduce yourself. So I am doctor this, you have to see in your station, okay, where you are located and what is your position. They are usually given, it is a ST5, it is a consultant, so you are a consultant. So that means you should tell, yes, I'm Dr. Mrudula, I'm consultant in antenatal clinic. So whatever the position of the thing which you have given in your station, okay, outside the cubicle the instruction paper will be there. There it must have been written whether you are a ST5, whether you are a consultant, okay. So depending upon that, you have to introduce yourself, form agenda for the station, okay. So you have to know what exactly you are going to do in that station and you have to tell that. So Dr. Jyoti will tell you in her part that how you are going to form this, and history taking. So history taking should be targeted and time bound, and this is the most important component of a simulated patient task or a role player task, okay. So today Dr. Jyoti is going to take in detail regarding the history, okay. So that then let role player speak. As I told you, the role player is the one who is there to pass you and not to fail you. So definitely let her speak. So she will tell you, she will bring you on the track. Okay, be a good listener. Always offer examination in presence of chaperone. That is most important thing. Okay, so always the chaperone word should be mentioned and the interpretation of the investigation given. So this comes in the information gathering domain. Okay, the next domain is communication with the patient. So again, as I told you, these are the interlinked domains. So introduce and greet the patient or role player, be polite with her, be a good listener, avoid medical jargons, use layman's words, use non-verbal communication. So whenever the patient, the role player is talking, do some gestures like move your head or something like that. That you should be you are attentive, and it should be seen or experienced by the examiner. Okay, so that is important, that you are attentive and you are listening to the role player. So you should not write, you should not keep on writing or look at your paper when the role player is talking. So these are the non-verbal communication is very important in these stations. Maintain eye to eye contact with the role player. Address her concern whenever she asks any question. Whenever role player asks any question, remember that it is related to your marks, okay. So it is going to gain or lose your marks whenever she asks any questions. So it is for you. So remember that whenever she asks any concerns or any questions, so it is related to your passing and failing of the station. Remember it and answer her like that. And don't interrupt while the role player is talking. It is very important in lay examiner station. Don't interrupt when the role player is talking. It is not a good sign, or it is not as a good communication skill. Okay. Then communication with the colleagues. So as I told you, you have to remember your role. So whatever is written in the instruction chart, you should remember whether you are a SP5, whether you are a consultant, and wherever you are posted. So whether you are in the antenatal clinic, in the labor ward, oncology clinic, whatever it is there, you should remember that thing very well. Okay. Then for communication with colleagues, see, MDT is a buzzword for passing part 3, multidisciplinary team. Okay, and this multidisciplinary team will not only involve doctors, but it involves other paramedical staffs also, like your midwives, your nurses, dietitian, physiotherapist, and all other paramedical theater assistants. So all these things will be required, and you should use these people appropriately. You should use your other colleagues. So you should involve always other colleagues like neonatologist, your anesthetist, then any oncologist. Then next thing is other whenever you are going to do the maternal medicine stations, your physician, epilepsy doctor, diabetic doctor. So all these things you should use these words everywhere. Okay, whenever. So MDT is a buzzword for this part 3 examination. You are not alone who are going to manage that patient, but there are other people, and it is a teamwork that you should always remember. It is a teamwork. You are not alone who is going to manage each and every patient and as a whole. Okay, so it is always a teamwork in UK, and you should involve all other peoples every time. Okay, involve non-medical staff also, and involve your senior colleague. So you should know that you are a SP5, and whenever anything is there, I will inform or I will discuss with my consultant, and I will get back to you. Okay, so we will take our consultant opinion also, though this is always there that you should tell. And then support groups, this is also again a buzzword for this. So for anything, there are so many support groups are available. If you don't know the names, it is okay. Like for ectopic pregnancy, it is Tommy's. Okay, there is a Tommy's support group, so you should know. For cancer, it is a Macmillan's. Okay, so that you should know that. For cervical cancer, it is a Joe's Trust. So there are something special support groups are there. If you remember the names, very good. If you don't remember the names, I will give you link of the support group also, so that you can have discussion with the people who are having within same condition like you. So this is the word, that sentence that you should use at the end of each station. Okay, so support group is also a thing that you should remember for each station. Now patient safety, it is a thing, this is a domain where many people fail in part 3 examination. Okay, so patient safety is the thing where many people fail. So remember that it is very important to be a safe doctor, and this is what the thing what they are going to see for you. Okay, so always what you are going to see for the patient safety point. So it is always, if the patient has any allergy, you have to always rule out any allergy, any chronic illnesses like diabetes, hypertension, all these things. Blood group, you should remember for all antenatal patients, any Rh negative anti-D you should not forget. Jehovah's Witness, that means whether the patient can accept the blood transfusion or not. In all antenatal cases and all operative cases, all surgical module, you should remember regarding the Jehovah's Witness. BMI, again, it is a most important thing. VT risk assessment, it is the non-forgettable part. Okay, you have to always ask regarding whether the patient has history of VTE or whether she has any risk factor for VTE. And thromboprophylaxis, you should mention in each and every station. Consent, you should do everything with the consent. Any procedure, you should never forget any instrument, needle or swab count. MDT is also always a part of patient safety, and explain all risk regarding that procedure or regarding that treatment plan. So all side effects. So all this comes under patient safety, and you should never forget these points. And applied clinical knowledge, this is a major part where your part 2 knowledge is going to help you. So any interpretation of results, you have to explain the diagnosis in the patient's language, and you have to formulate a management plan. And whenever you are formulating a management plan, it is not a surgery or it is not a drugs, but it is a holistic management plan. So it should start with lifestyle modification. Any modification, so any management, it should start with lifestyle modification, and it should end with the surgical management. Okay, so that thing you should remember. So for anything, you have to start with lifestyle modification or conservative management. You have any your management plan, it should be patient centered. You have to give all of the option, and patient will choose. Okay, so it is a patient center this thing treatment. You have to give all options to her. You have to explain all benefits and risks of each management to her, and let the patient decide. Avoid any paternalistic attitude. So this is the most important part regarding her management plan or applied clinical knowledge. Okay, so This is regarding your basic thing, how you are going to do your preparation. Now coming to, we will now discuss two stations. Okay, one I'm going to take one teaching station and one structure discussion. And after that, Dr. Jyoti is going to tell you regarding the history taking, and she will take one role player task. Okay, so I want volunteer who is going to do for this. First thing, I'm going to take a teaching station. So who wants to be a volunteer? Yes, anyone volunteer? Yes, dear. Nobody wants to become volunteer. I will be happy if any new people come forward. Or there are so many old people. They also can. They can be also volunteer. But I will be happy if any new people come forward to become volunteer. So who will be doing the station? Anyone? Nobody wants to. Anybody from the old people?
Hello, Dr.
Everyone?
Mrudula.
Yes. Surabhi, you want to do?
Yeah,
Okay.
I want.
Okay, nobody wants to come. It will be a easy station for you, my dear. But okay, nobody wants to come forward because I have taken very easy stations, because considering you will be the new people who will be doing the stations. Okay, if nobody wants to do, no problem. Okay, Surabhi, yes, you can do. Okay, so I will start your 2 minutes and I will start the station. Okay,
Okay.
Surabhi, yeah. So yes, whenever you want to move to the next, tell me. Okay, I have started your 2 minutes.
Yeah, next slide.
Yeah. There is one more slide.
Okay. Next slide. Can I see the first slide?
Yeah.
Second.
Yes, your time is up. You can start. I will start your 10 minutes.
Yeah. Hello, I'm Surbhi, ST5. And you?
Hello, Survi. I'm Sarah and I'm ST1.
How would you like me to call you?
Sarah will be fine.
Okay, Sarah. How are you doing, Sarah?
I'm fine. I'm very much enjoying my training here. I'm just newly posted in this unit and I'm enjoying here. Thank you very much.
Okay, Sarah. In case you have any kind of problem in the department, please feel free to come to me. Okay?
Sure, sure.
Okay. So, as I know that you want to learn about the episiotomy, is that correct, Sarah?
Yes, yes.
Okay. Any particular concern why you want to learn about episiotomy?
Yes, actually, doctor, I was posted. I have previously worked in Africa, and there we used to do so many deliveries, and I used to do episiotomies also. But when I came here, I found the technique is totally different. See, you can see here. I can. I was used to do the. Just 1 minute. So we used to cut like this, okay? And we
Yeah.
used to do the episiotomies. But when I came here, I found out that these are totally different things here people are doing. So I want to know much more about it.
Yeah, that's very good of you, Sarah, that you have come to learn about it. Because in UK we follow the mediolateral type of episiotomy, like what you are saying, it is called mediolateral technique. Okay,
Oh,
so
okay.
yeah, so the technique which you follow is the midline episiotomy, which is also good, but there is a risk that because the anal sphincter is near to the midline, it might get damaged. Therefore, we prefer the mediolateral technique. Am I clear, Sarah?
Okay, okay. I got it. Yeah, thank you. Yeah.
Yeah. So in this mediolateral technique, we give the cut at angle of 60 degree. In this way, the anal
Mhm.
sphincter is prevented from damage. Okay, Sarah?
Okay. Yes,
Okay.
yes.
Can you please repeat at what angle we give the cut?
Yes, it is at 60 degrees, correct?
Yeah, very good. 60 degree.
Mhm.
Okay. So, Sarah, what do you know about episiotomy? Are you aware of the muscles which we cut?
Yeah, I know this theoretical part like this superficial and deep transverse muscles are cut and this thing. But yes, yeah, that is the only things, no? These are the muscles
Yes.
which are cut. Yeah.
Yeah, yeah. Okay. And when you give this cut, we infiltrate so that the area is numb and the patient does not feel the pain, right?
Oh,
So,
yes, yes, yeah.
yeah, you must be infiltrating before giving the midline episiotomy in Central Africa, right?
Yes, yes. Yeah, we
Yeah.
used to
So
use
likewise,
this.
likewise we infiltrate here also because we need to take the consent from the patient. We need to inform the patient that we are going to give a cut and we are numbing this area. You will not feel the pain. Okay. And before
Okay,
infiltrating, yeah, we also do the testing, sensitivity testing with the local
okay,
anesthetic. Yeah, we need to
okay,
rule out the allergy. Maybe some patient may be allergic to the local anesthetic. That's why we do the sensitivity test beforehand. Okay, Sarah?
okay.
Hello?
Yeah. Yes, yes.
Okay.
Yeah.
Yeah. So we need to assess at what point we need to give the episiotomy. So not every patient need the episiotomy. We see whosoever needs the episiotomy at the time of crowning. If we want to deliver the head, we see that the crowning is there and the vulva is stretching, the head is not receding back, and there is a requirement to increase the room for the delivery of the head. We give the episiotomy at 60-degree angle. Okay, so now I will show
Okay,
how we will give it in this model. Like this is the perineum. Okay, we safeguard the head of the baby by inserting our two fingers of the left hand inside it like this. Okay,
yes.
yeah. Will you like to do?
Yeah, yes, yes. Like this. Is it
Yes,
correct?
yes,
You
very
are going
good.
to introduce, yeah, two fingers
Yeah,
inside, correct? Yeah.
yeah. And this is the episiotomy scissor. Okay,
Okay.
and
Okay.
this is the needle the needle which is coming out of it. This will help in knowing the angle. It is at the
Okay.
angle of 60-degree, so it will help us
Mhm.
where we need to cut. Okay,
Okay.
yeah,
Okay.
you can hold it and see.
Yes, yes. I got it. So this outwards,
Yeah,
this thing knob is for the angle, correct?
yeah,
So that we should
this is
give it
for
at
the
correct
angle.
angle. Yeah.
Yeah,
Okay.
yeah. So when the perineum is straight, the crowning is there, we give the cut in this place. Okay, and
Okay.
when the head
One
is
more thing.
delivered, yeah,
Okay. One more thing I
yes,
wanted to
please.
ask. We used to give in Africa all patients, but here I have seen that people are not giving for all patients. They are just giving if it is required. So is it that we should not give for all patients episiotomy, correct?
Yes, yes. In the beginning only, I told you that not every patient requires the episiotomy.
Mm-hmm.
It is only required when we find that the vulva is not stretching in that manner. Like most of the multiparous women, the vulva is stretchable. So there is
Okay.
no need to give the episiotomy. Even in the primary, if we find that the head is small and can come out easily, then we don't give the episiotomy.
Okay. Okay. Got it.
Okay, Sarah? Yeah.
Yes.
Okay. Anything else you want me to address about the cut we give with the
No.
scissor?
No.
Okay.
Yeah.
So after the delivery of the baby, we see the placenta. If it is separated, we take out the placenta and check for the membranes or any parts of the placenta and see for the PPH. And
Yeah.
after that, we take the vicryl rapid to suture the episiotomy. Okay, Sarah?
Okay. Okay.
Do you
Okay.
want me
Yeah.
to go through the suturing of the episiotomy also?
Yes, it's better if you tell me how exactly how to suture it. Yeah.
Yeah, so the most important point is the apex. We need to find out the apex, and we should give the stitch with the vicryl rapid 1 centimeter above the apex.
Okay.
Okay, and then we will, in the continuous manner, we will stitch the first layer.
Okay.
Okay, and the second layer, we take the muscles, which can be intermittent. Some people take it in the continuous manner also. Okay, Sarah?
Okay.
Yeah, and then third is the skin, which can be stitched in the subcutaneous manner also and intermittent way also. Am I clear,
Okay.
Sarah?
Okay. Yes. Yeah. One thing is
Okay.
there, mucosa, can we do it in like locking? People should do it in locking. We used to do it in locking stitches. So should we do it locking or non-locking stitch?
Which one? Vaginal one you're saying?
Vaginal mucosa. Yeah.
No, it is vaginal is done in a non-locking stitch only because
Okay.
it might lead to then shortening of vagina also if and necrosis also if we do it in continuous locking.
Okay. Okay.
Okay. And anything else you want me to address, Sarah?
No, yes, it's okay. Yeah. I got talk about the technique, how to do it. Yeah. Thank you very
Yeah,
much.
and after that, we tell the patient to maintain the hygiene of the perineum, and we also tell them to clean the area whenever the patient goes for the toilet and pass the urine. And we make sure that after the delivery and episiotomy, the patient passes the urine within 6 hours. Okay, Sarah?
Okay.
Yeah.
Yeah. Thank
So
you.
I will be giving you the link for the RCOG. There is a RCOG video about the episiotomy technique. You can go through it, and I will also, if you want, I can fix another appointment also to show you how the episiotomy is done. Okay, Sarah?
Yes. Yeah.
Yeah.
Yes, doctor.
Okay.
And one thing is that, as I told you, I can do the suturing and everything. No. So can you sign this form for me? Because I know the suturing and all these things. So can you sign this form for me?
Yeah, Sarah, I realize that you are really very enthusiastic, and this is the form which is the supervised learning event form. So actually, you need to do it before I sign this form. So first, you try it on the model, and then you can do it. And after that, I can fill this form for you. Will that be fine, Sarah?
Yeah, actually, yes, but I wanted to do this competency immediately. Actually, I am under the pressure to complete this task. So, can you do it for me? Because, as I told you, I have sutured so many episiotomies. So, can you do it for me? Sign it for me.
Sarah, actually, I cannot sign it for you at present because once you do it, then I can surely sign it. And you need to tell me that you want this form to be filled beforehand, and then I can do it for you. Okay, Sarah?
Okay. Okay. So, yeah, thank you. Okay. Next time, I will definitely, whenever a patient is there, I will tell you, and beforehand, I will give you the forms, and then you can sign it. I will show it how to do it. Is it
Yes,
okay?
yes, Sarah, sure, sure. And how was the session, Sarah? How did it go?
Yeah, it was very good actually. I was not knowing that that mediolateral episiotomy very good. So thank you very much for telling me this technique. Thank you very much. So
Yeah,
yes,
and
Surabhi, your
Sarah,
time is also up. Yeah,
okay, thank you for your
yeah,
time.
no problem. No, yes, you have finished in time only. So yeah. So coming to your feedback, I think you don't need feedback for episiotomy teaching, Surabhi, but still,
No,
but
actually, I know I missed the point. Actually, while doing, we tend to miss the point. I don't know why.
Yeah, it was a recall station for me also. It was exam station for me, and I also missed points in my station in the exam also.
Mm-hmm.
Okay, so yes, it happens. Whatever simple is a station, it happens that we miss some things. So coming to the your introduction and all these things, yes. So just I will give you feedback while I am telling the key to this, because so that the new people will exactly know how to do the station. Okay, Surabhi. So I will just give
Yeah.
you feedback while coming to going to through the key only. Okay.
Okay.
So first thing, see, as she has introduced, you have to introduce like that. You should not say that I am doctor so and so. Okay. For any teaching station, it should be you should call your name only. You should tell your name only. So it should like, yes, hello, I'm Mrudula, I'm ST5, and you are okay. So you should tell your this thing designation, whether you are ST4, ST5 here, because in SPT it is not required to tell your designation whether you are ST5, but you have to tell like I'm a senior doctor in the clinic, okay, because the people don't know that what is ST4, ST5 or a consultant, but there you have to tell a senior doctor, but in teaching station you have to tell your designation. So hello, I'm Mrudula, I'm ST5. That will be your introduction for your teaching station, and you should not call yourself a doctor, just tell your name. Then after her introduction, you have to always call her by her name. Okay, always you have to call her by her name. That is the thing, most important part of the communication. Then once the introduction is over, the first thing you have to ask her regarding how her training is going on. That is important. Here the thing where you have to find out if there is any undermining, any bullying, or any difficulties she is finding in adjusting with the environment. So that is the thing that you should find out, because sometimes the station will go in the undermining and bullying thing, and if you don't identify that, because people see the station outside the cubicle, it is not written that it is undermining or bullying station, but here from the trainee's perspective or from the trainee's communication, you have to find out whether it is a undermining or bullying station, or it is a routine teaching station. Okay, so for that, in the initial stages only, you have to rule out any undermining and bullying. And it is not that always trainee is going to tell you that I am getting bullied, but see, you will she will tell her that, see, now she told that she is already done in Africa and she wants to learn because this technique is different. Okay, so that's why. But if she would have been undermining or getting bullied, then she will tell that, no, that my senior is there and he is always shouting on me because I'm always doing this wrong. Okay, I'm always doing this wrong, and my senior, he is always or she is always shouting on me, or my senior midwife, she is always shouting on me. Okay, so in that thing, you are going to find out whether it is a undermining or bullying one, or if she is not talking to you. See, I don't feel like that I should continue this. I don't feel like that I can't do this episiotomy anymore. I don't know. I have done so many in the past, but now I don't think I know this episiotomy. Okay, so if she tells you like that, you should take her that clue that yes, there is some problem, there is some undermining or bullying that you have to find out. Okay, after this ruling out undermining or bullying, then you have to ask her, yes, why she wants to learn that technique. Okay, why she wants to learn episiotomy, any specific concerns, whether why she wants to learn. And after that, where Surabhi has missed here, so till undermining and bullying, everything she told. She ruled out undermining and bullying. She asked why she wants to learn episiotomy. Till that, she was very correct. Now form the agenda. Okay, so here, why forming the agenda in the beginning itself is important is, here you have to tell, so yes, Sarah, I will tell you regarding the episiotomy. So I will tell you the indications and contraindications for giving episiotomy, the technique of episiotomy, what are the prerequisites for episiotomy, what is the indications, contraindications, post-procedure care. So you have to follow a certain format. Okay, I will tell you regarding the post-procedure care, and at the end, I will give you some reading material or learning resources. Okay, so this is most important thing that you have to tell. She told at the end. Okay, I will give you some videos to see, so where you can watch how this technique to be done, how the episiotomy to be sutured, and you will be perfect with that. So that is the thing. She offered that learning resources, but sometimes what happens? Your 10 minutes is already finished. The time will not be sufficient at the end to tell you that sentence. but this is very important that you have to offer her the learning resources. So if you have told it in the beginning itself only in the agenda, then you are going to get those marks. So for that, this formation of agenda is important. Then next, talk slowly, ask frequently whether the trainee is following you. So here she was asking, correct? See, where are you with me? Are you getting that? So till now, is it clear? So these are the things that you should ask frequently. So whether the trainee is understanding what you are talking, that is important. And then you have to ask one or twice whether she has understood that. So you have to ask, like if you told any indications, okay, so can you repeat these indications for me? Like she asked me what is the angle, okay, so she asked, so she just confirmed it whether I'm following it or not. And whenever there are any instruments, see here there was a episiotomy scissor, so she offered me to hold it, okay. So whenever there are any props on the table, you have to offer that thing to hold, okay. So use those props and you ask the trainee also to use those props. That is also important. It also carry the marks. And at the end, as I told you, give reading material and learning resources. So all these things she has done. Now in the proper episiotomy technique, what exactly you should tell. So this is the thing. That is the pre-procedure. What are the things to be done? Indication, contraindication, consent, anesthesia, actual procedure, precautions, needle and swab counts, where she forgot, post-op procedure care, and any red flag sign and when she should follow. Okay, so these are the things. Whenever you are teaching any procedure, these are the points you should always cover. You should not miss any of the points. Okay, because see here, needle and swab counts, this is patient safety. Consent is patient safety. Anesthesia is patient safety. Red flag signs and post procedure care. All these points, this comes under patient safety. So first thing, as she told you, yes, first you have to explain the patient. Whenever before giving episiotomy, you have to tell her that this we want to make a room for your baby. So for that we want to give you cut. So this is the thing that you are going to explain to the patient, and you have to tell to the trainee also. You have to explain to the patient in these words. Okay. So we are going to give you a cut on your down below, so as to make a room for your baby. Okay. Then consent for episiotomy, it is a verbal consent. So she told regarding consent, but remember that it is a verbal consent. Okay. Then anesthesia, she told regarding the infiltration. If you get time, you can tell the dose of lignocaine also, but if you don't tell, nothing happens, doesn't matter. And what are the other anesthesias we can use? So pudendal block and epidural. And see here, indications you have to tell. So I asked her whether she told previously also, but it was a very short this thing. So indication here you have to stress that in UK, episiotomy is not given for every patient. Okay, so you have to tell that episiotomy is not required for all females, but it is only for certain procedures like for instrumental vaginal delivery, shoulder dystocia, breech deliveries, and if you feel that the perineum is inadequate. Okay. Then timing of episiotomy, it is at the crowning. Type of episiotomy, right mediolateral episiotomy, which is commonly used in the UK, and angle 60 degree, which she also mentioned. Okay, and see the scissors which are there. These are EP scissors. These are known as EP scissor, and this is the thing. See, this knob will point towards the anal sphincter, and then the angle will be maintained at 60 degrees. So you have to tell her the specific use of this EP scissors. Okay. Then after giving the episiotomy, after you give the episiotomy, after the delivery of the baby, before suturing, whatever things you have to confirm. So first you have to see that all the instruments for suturing are available. Good lightening is there. Complete removal of placenta is there. Rule out any third, fourth degree tears or any other tears. Patient is under anesthesia or analgesia, that is local infiltration is done or not. So all these things you have to check before suturing. These things she somewhat forgot some things. Then check apex, start suturing above the apex, 0.5 to 1 centimeter above the apex. Suture material, she told directly the thing name of Vicryl rapid. So it is better to use the generic word, that is polyglactin 20. Okay, it is Vicryl rapid 20 correct, but it is a polyglactin 20. Then again you have to tell the sutures. So for mucosa it is continuous non-locking. For muscles, it can be intermittent or continuous, and for skin, it is subcuticular sutures. So you have to tell the type of sutures also. After suturing, you have to do pervaginal or rectal examination. You have to remove any swabs which you have inserted, check swab needle and thread count, and then post-procedure care. So post-procedure care, you have to tell her regarding the voiding or emptying of her bladder, seats bath, and wound care. And then red flag signs means if she finds any severe pain at the episiotomy site, any discharge from the wound, she has to immediately report to the care, clinical care. Okay. So this is regarding her episiotomy station. So all this thing you have to tell, and then comes the main part of the station. Okay. So this is regarding this OSAT form. So whatever she has shown here, the trainee has asked you to fill. See here, you can see it is a formative OSAT. Okay. So there are two types of OSATs. OSAT means it is an objective structured assessment of technical skills. Okay. So here the trainees has to complete typical OSAT forms for going to the next year, or for the promotion of from ST1 to ST2, ST2 to ST3, they have to complete typical number of OSATs. Okay. So these are the validated assessment. It is the workplace based assessment basically to assess your competency. And these are formative and summative. These are two types of OSATs. So here you can see it was a formative OSAT. So what is the difference between formative OSAT and summative OSAT? So whenever the trainee gives you any form, you have to see whether it is a formative OSAT or summative OSAT. Now, if it is a summative OSAT, it is for the competency. While for formative OSAT, it is only for the practice and feedback, whether she is doing the technique rightly or not. While summative OSAT is for signing off or for showing her competence. So for this, you have to first see whether these are formative OSAT and summative OSAT. Whatever is the OSAT, you can sign it. But given that, so what is the criteria where you can sign those OSAT is first thing. So these are the OSATs. So this you can get on the RCOG site. So these are the different types of OSAT that you should complete, that the trainee should complete. So these are the compulsory OSAT. These are the other procedure OSAT. So that is Mirena, Bartholin sepsis, and cervical cerclage. These are the other OSATs that is desirable to do. But these are the compulsory. This should be completed before the ST5. Okay. So whenever any OSAT is there, whenever any form of OSAT, so the trainee should tell you in advance that I have came for this formative or summative assessment. And even he or she has to tell whether it is a formative OSAT form or summative OSAT form in the beginning only, whether she wants to get signed up for this formative OSAT or summative OSAT. She can't be able to upgrade from formative to summative. See, if the formative has gone well, she has excellently suited episiotomy and she has come for formative assessment, then she can't upgrade herself for summative OSAT. Okay. So it is in the beginning only. So whenever she has started the station, if she has shown you the formative OSAT form, then you can sign it. Okay. If she has performed well, you can sign it. Otherwise, if she has shown at the end, you cannot sign it. Whatever it is, whether it is a formative or summative, you cannot sign. If at the beginning, if she has shown, that is also important. If in the beginning, if the trainee has shown you the OSAT form, you have to see whether it is a formative or summative. Okay. And at the end, if she had changed from formative to summative, again you can't sign, because these are the things which are usually done in the stations and recalls. Okay. So first trainee will show formative OSAT form, and then at the end she will give you summative OSAT form. In that case, you are not able to, you should not sign that. Okay. And there should be different assessors to sign off. So it is all three. There should be 3 formative, 3 summative minimum. Okay. For one procedure, there should be 3 formative assessment, 3 summative assessments. OSAT should be signed off, and all should be done by at least there should be 2 different assessors. So 3 formative OSATs. It is not that all one assessor will sign all the 3 formative or all the 3 summatives. So you should not use the same assessor for all OSAT. And for summative OSAT, at least one OSAT will be signed by a consultant. Okay. So yes, definitely ST5 can sign for episiotomy OSAT of ST1. summative OSAT also. So previously they used to tell that summative OSAT should not be signed by ST5. So it is not like that. For simple OSAT, you can sign this summative OSAT also, provided that the trainee has shown you that summative assessment form previously only. Okay. And consent is not part of OSAT. And once you complete your OSAT, it is the one thing that every year you have to do one annual OSAT, okay, to demonstrate continuing competence. So this is for this episiotomy teaching station. Any doubts you have regarding this station?
No,
Any
thank you
doubts?
so much, Dr. Mrudula. Thank you so much.
Thank you, Surbiya. Okay, so now we will proceed to one more station. So this is the structure discussion. Anybody volunteered for the structure discussion?
Can I, Dr. Mrudula?
Shraddha, okay. Nobody from the new group wants to do, because all these are old one. They are already doing, they're already practicing very well. Okay, so definitely they are going to do it well. So anybody from the new people want to try it? Otherwise, yes, definitely Shraddha, you are going to do it. Okay, no problem. Yes, Shraddha, you will be doing this.
Yes.
I will start your 2 minutes.
Okay.
Just 1 minute. Just 1 minute. Let me start your 2 minutes. Yeah. This is your first slide.
Yeah. Next slide, please.
Yeah. Actually, these are very simple stations I have taken today, so I don't wanted old people to do it, but okay, no problem. Shraddha, some background noise is there.
Yeah. Yes, just 1 minute.
Can you hear? Yeah. Actually, your time is also up. Okay, tell me when you are ready. So shall I start?
Yes, yes.
Okay.
Hello, I'm Dr. Shraddha. I'm one of the exam candidate. I'm happy to start the structured discussion.
Okay, doctor. So as you have read this scenario, what will be your immediate management in this case?
Yeah. So in this scenario, I'm doing a total abdominal hysterectomy where I suspect right ureteric damage. So in this case, first of all, I informed the anesthetist that the injury has taken place. The surgery is going to be prolonged, and and please give additional sort, and the patient may require additional sort of antibiotic. Then I would ask one of the circulating nurse to inform the consultant, because ureteric injury is it is beyond my scope. I need the help of my consultant. And also I'll ask her to arrange an additional pair of instruments for repair of the ureteric injury. I'll ask
Okay.
because the surgery is planned in spinal anesthesia. I'll ask one of the nurse to counsel the patient that the injury has taken place, but we are there going to manage it.
Okay. Okay. So shall I move on to the next question?
Yes,
So now how you are going to identify that this is a ureteric injury?
yes. Now, if this is a ureteric injury, so I will either identify that there is urine coming out into the cavity,
Mm-hmm.
but I need to confirm it. So for confirming it, and also there would be in the euro bag also, there may be blood in the euro bag. But to confirm it, I need to involve my consultant. The consultant may involve the urologist, who will either perform a cystoscopy to confirm the diagnosis, whether the ureteric injury has taken place.
Okay.
Other could be a double dye test, where we inject one dye intravenously. I think it is indigo carmine from above, and from below it is below another dye is injected. If it is indigo carmine, if it comes out through the because it is rapidly absorbed through the blood vessels and excreted by the urine. So if there is by the kidneys, so if there is injury, it will the orange color dye will be seen in the field.
Okay. Okay. So once you have identified that it is a ureteric injury at around just below the uterine artery or near the cervix, so what are the principles to manage the ureteric or repair the ureteric injury?
Yeah. So ureteric injury will be done by a person who is competent in doing it, either my consultant or the urologist. The principles of repair of ureteric injury because it is at the level of urethra, uh, at the level of the isthmus, so it will be ureterostomy, or it will be ureterostomy, or it could be transureterostomy, because bladder is not near. If it is close to the bladder, then that is in the distal 1/3, then we can do the psoas hitch or Boris flap. While if it is ureterostomy, the principles of repair is that it should be watertight, and it should be fist mouth. It should be done with Vicryl 30 or 20, and there should be minimum use of energy. And after repairing, we should reconfirm it that there is no leak.
Okay. Okay. So next question, how you are going to manage? So actually you have told that question only, but again I will tell you, I will ask you that how you are going to manage this ureteric injury. So how you are going to manage your case now?
Yeah. So now the injury has taken place, and we have repaired it by involving the consultant and urologist. Now after repair, we will put the Foley's catheter for at least 10 days.
Mhm.
Then after putting the Foley's catheter, and once the patient recover, and I will document it in the post-operative note. I'll make sure that additional antibiotic is given,
No,
because
I'm not asking about post-operative. I'm asking about the intraoperative management only in your patient.
yeah, so intraoperative management includes repair of the ureter, which is with the involving the consultant, and it should be watertight, it should be fist mouth.
Mhm.
um, uh, and then once we have repaired the ureter, we will
Mhm.
complete the surgery. We will
Mhm.
do the sign off,
Mhm.
and And prior to closing the abdomen, we will check all the 3 stumps that there is no leakage from in the all the stumps are well secured, and then we will after doing the sign off, we will complete the surgery and
Okay.
close the abdomen and put the
Okay.
Foley's
So,
on.
okay. So now what will be her post-operative management?
Yeah. Once I finish the surgery, I will document the entire procedure. I will offer her additional course of antibiotic because there is she's at risk of infection. There will be Foley's for 10 days. Her stay in the hospital may be prolonged, so she will be assessed for the risk of DVT prophylaxis, and she will be and if she is at risk, DVT prophylaxis will be given. At the same time, for the other things, I will follow the principle of enhanced recovery. That is, once he is able to drink, he will be encouraged to drink and eat and move around. And once he is in the full, he can understand the thing, we will debrief the patient about what has taken place, that injury has taken place, and we have repaired, and she will require additional follow-up. Then during I may expect anger from the patient, so I'll try to cool it off. Also, then I have to fill the datex form. After debriefing, I will make sure that I have filled the datex form, document it, and include this case also in my e-portfolio so that I can present this. This will be included in my annual competence of annual review of competence program, which I will submit during my year end,
Okay.
and discuss this case with my tutor also.
Oh, okay. So yes, my questions are over. Anything you want to add, or should we go to the feedback? Still almost 1.5 minutes is remaining.
I'm just thinking, Doctor.
Okay, no problem. There is still time.
Yeah, her follow-up after the surgery will be after 10 days will be with the urologist, or 2 weeks will be along with the in the gynae department. It will be with the urologist also.
Okay. Anything extra? Anything more to add?
And prior to giving the antibiotic, we will check her notes that she has not allergy to the antibiotic which we are giving.
Okay.
That's all, Doctor. Thank you so much.
Okay. Okay.
Thank you for your
Thank you.
time.
Okay. Thank you. So yes, 20 seconds were remaining. No problem. So Shraddha, done well. But what you will tell regarding your station?
I
Any
maybe
feedback from your side?
I think I could have something I was missing, like how to
Yeah.
diagnose. Maybe I could have added cystoscopy.
Yes.
We will assess whether this will require stenting or repair. It is
Yeah.
partial cut or complete cut.
Yes. 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 Okay. So I think yes, some knowledge. I think there is so much gap is there. That's why something was missing. See, for structure discussion, you require thorough knowledge. Okay. So and this talk you should be very thorough with ureteric and bladder injuries, okay, because they are routinely come for post-operative complications, and this is the talk that you should be very thorough with regarding how to do the bladder repair, ureteric repair, okay. So coming to your feedback and as a station as a whole, so first thing, See, as she has introduced, you have to introduce yourself whenever you enter the cubicle. Okay, whenever it is a structured discussion, you have to tell the examiner that I'm Dr. So and so I'm Dr. Mrudula. I'm the exam candidate, and I have read the scenario. I'm ready for the discussion. These should be your standard lines for introduction for structured discussion. So for each thing, introduction is different. For SPT, introduction is different. For teaching station, introduction is different. And for structured discussion, introduction is different. So here introduction will be, I'm Dr. So and so. I have read the scenario. I'm the exam candidate. I'm ready to start the discussion. Now here the first question, what will be your immediate management? So you see here the consultant is already, the consultant is not in the hospital, remember well. Okay, so here you have to read the scenario very well. Now the consultant is away from the hospital for a meeting. So you should be aware of the situation. This is called a situational awareness. So now whenever you ask that what will be your immediate management, you have to first present this case in the SBA format. So this is a patient. I'm doing a, as she told you, I'm doing a total abdominal hysterectomy for a HMD patient, and while doing the hysterectomy, while at the wall closure, I have found that I may have accidentally injured the right ureter. Okay, so first thing I will do here is I will stop the surgery after confirming that there is no active bleeding. That is the first thing that you should do. Okay, so I will first stop the surgery, and first I will confirm that there is no active bleeding. If there is any active bleeding, you have to stop it. Okay, and then you have to stop the surgery. Inform the anesthetist and the related staff. Now you don't know. Now she told here that the patient is in spinal anesthesia, but it is not mentioned anywhere in the station whether the patient is under spinal or GA. Okay, so first you have to tell the anesthetist regarding such and such possible complication has occurred. You have to also tell your circulating nurse and scrub nurse also. So circulating nurse will, you have to tell her to inform the consultant, and if the consultant can't come immediately, you have to inform on-call consultant. So see, if your consultant cannot come immediately, then you have to inform, there will be always a on-call consultant. So you have to inform on-call consultant so that that consultant can attend the surgery immediately, because it is a complication which is beyond your scope of repair. Okay, so consultant has to attend it. Then see, it is a ureteric injury. Ureteric injury, it should be informed to the urosurgeon. Okay, see, bladder injury, if the consultant is competent enough, bladder injury, he can repair or he can inform urosurgeon. But better for ureteric injury, it is always the urosurgeon who is going to repair or who is going to take decision regarding this ureteric injury. So inform your consultant plus urosurgeon. Tell the scrub nurse and circulating nurse to arrange for extra instruments. Tell the anesthetist if any additional investigations are required, to administer extra shot and to see for the blood loss also. Okay, extended time. So all this thing you should tell. Then cover the wound with wet gauze. That is also very important, because till the consultant arrives, you are not going to do anything. So you have to cover the wound with wet gauze. Now, if in case of C-section, if it is in case of cesarean section, if you have suspecting any injury, then you have to make sure that you have delivered the baby. Okay, so first you have to deliver the baby, deliver the placenta, and then stop the surgery. In case of cesarean section, if you are suspecting any bladder injury, then in that case, you have to deliver the baby, you have to deliver the placenta, and then stop the surgery. Okay. Now, if the patient here, you have to tell the examiner that if the patient is under regional anesthesia, then I will inform the patient in sensitive manner that some complication is occurred, but don't worry that we are going to handle it and it will be managed very well. So don't worry. Okay, so that is the thing that you should tell. You have to tell that complication has occurred, but you have to tell her that we are competent enough to manage it. So this will be your immediate management. Now, next question, how will you identify the ureteric injury? Now, don't go in all these three details, but see, you have to see, so when the consultant arrives, you will see whether it is a ureteric injury or not, and how you are going to identify the ureteric injury. So one thing is cystoscopy. Okay, Cystoscopy, it will allow visualize the ureteric orifices and urine jets, whether there are there or not, presence of blood or air. Okay. Also in Urobag, whether the presence of blood is there or not, you have to see. Another thing is intravenous indigo carmine dye, which she has told. Actually, what she was telling everything correct. Only thing she was dumbing somewhat. I think because of so many days she must have not read this. That's why there was somewhat dumbling was there. But yes, it was a indigo carmine dye injection, IV injection. So you have to see whether the dye is coming out in the abdominal cavity, so that you can do it, or you can also see the laparoscopically or cystoscopic assessment. So these are the things that you should do for identifying the intraoperative ureteric injury. Okay. And then you have to see also inserting the stent, because this is the thing that you have to finally do. You have to insert the stent at the end of ureteric repair also. So stenting should be done. So you have to see whether the stents are coming out in the abdominal cavity or not. After inserting the stent under the from the cystoscopy, if you insert the stent, if they are coming out directly in the abdominal cavity, that means it is a ureteric injury. Now this talk is for laparoscopic injury also, so they have given this laparoscopic assessment also. Okay. After this, once you have identified the ureteric injury, now where the Shraddha confused is principles of management and how she is going to manage this ureteric injury. So in these two questions, she confused herself. Correct, Shraddha? So
Yes, actually, I missed
yeah,
these 7 points. Only few I
yeah.
could remember.
Yes. So these are the basic things that you should remember regarding these principles of management of ureteric injury. So first of all, the competent person should do that. That means neurosurgeon should repair the ureteric injury. First, you should determine what is the type of injury, whether it is a transection, whether it is kinking, whatever is the. So you have to identify the type of ureteric injury. Then, if it is a transaction or which requires repair, then first it is the complete debridement. Okay. Then careful dissection to avoid devascularization. And then regarding anastomosis, it must be watertight, tension-free, fish mouth or spatulated. You should use absorbable intermittent sutures, avoid too many sutures, use drainage, cover with omental flap, and if possible repair by laparoscopy. Now it is a open surgery, so this thing doesn't come, so repair by laparoscopy will not come, but all other comes as a principle of repair of ureteric injury. So these all things you should tell at least 4-5 things. She told at least 4 to 5 things. She told Vicryl, she told this thing debridement, she told watertight, tension free, fish mouth. So these all things she told, but some things she forgot. So you should know these all principles of ureteric injury repair. Then how you are going to manage this ureteric injury in your case. So it is a transaction. So now this is a Sri Shraddha, it is a lower, it is near the cervix, correct? So it is a lower third, it
Yes.
is not middle third. It is lower
Yeah.
third, so it is a bladder implanting. Okay, it is a
Okay.
reimplantation of ureter in the bladder only. It is
Okay.
not ureterostomy. It is a lower third ureteric injury.
Yeah. Yeah.
So it is a implantation
Boris
into the
flap or
bladder.
sausage.
And if it is a
But we.
shortening, no, it is not always Boris flap or psoasage. If you can't do tension free, then only
Yeah.
it is psoasage or Boris flap. If you
Yeah.
can do it without tension, it will be direct reimplantation in the bladder. Okay. So if there is a
Yes.
shortening, then only you are going to do psoasage or Boris flap. So this is now here. So you should not tell all these things here. Only you have to tell her that, tell the examiner that. So as this injury is near the cervix, so it is a lower third ureteric injury. So this requires reimplantation of ureter into the bladder. So it can be done either by ureteroneocystostomy, or if there is a shortening of ureter, you can do either psoasage or Boris flap. Okay. Now all these details they will not ask what is psoasage or Boris flap. If they have time or if they feel like asking, they can ask. Otherwise, this is the sufficient answer. So here you should not tell how you are going to repair upper third or middle third. Okay. So in structured discussion, remember well that it is not that if you have time also, you should not talk extra also. It is a lower third. You have to tell repair about lower third only. Okay. So this is regarding this ureteric injury. Now post-operative management. Then after this, you repair the ureteric injury. You have to complete your hysterectomy, correct? You have to do the vault closure. You have to secure the hemostasis, you have to confirm the needle swab count, and you have to close the abdomen. You have to insert, so before that you have to insert the ureteric stents and Foley's catheter, correct? So Foley's catheter will be already there. So all these things you have to do. Then you have to close the abdomen. You have to sign off that WHO checklist, okay? And then you have to document it. So this completes your surgery, okay? So this completes your how you are going to manage your ureteric injury. Got it? And then after that, the last question, how you are going to manage this patient post-operatively. So whenever any complication is there, post-operative complication, any structure discussion regarding post-operative complication, always better to divide post-operative management into the clinical management and clinical governance management, okay? So that it is easy for examiner to mark you. Got it? So you should not mix these two things, so that you also can forget some things in that case. So better to divide. So whenever you are answering the examiner, so the post-operative management, it is done on the two levels. One is clinical management and one is clinical governance management. So in the clinical management, this patient, so careful documentation of the case will be done in the post-operative notes. Okay. This patient will be shifted to either ICU or HDU. Important. Okay. Post-operative monitoring will be done by this new chart. Okay. Modified early warning score chart. Drainage will be there. So drainage, we will confirm whether the drain is patent or not. So Foley's catheter and drain, both patency should be checked. She should be given appropriate antibiotics. Catheter should be there for 2 weeks. Thromboprophylaxis, so she is, because increase period of surgery, so extended period of surgery, she will be again assessed for the thromboprophylaxis. And for now here, one thing is there, enhanced recovery program, it doesn't apply to the complicated cases. Okay, so now here don't utter enhanced recovery program, but yes, for cesarean section, hysterectomies and all other cases, you should always mention enhanced recovery program, but you should not mention enhanced recovery in case of any complications. Okay, so here you have to see, you have to definitely you have to advise for early mobilization. You have to see for the bowel sound, you have to start her on orals, and once the patient is comfortable at the day 2 or 3, you can discharge her. Okay, on the advice on discharge, what you are going to tell her regarding all warning signs like any fever, any wound discharge, and any urinary burning. So all these things, and she should be attend for the catheter removal at 2 weeks and urology follow up for the stent removal. Okay, so all these things will be her post-operative management, clinical management. And clinical governance management is, so I will properly document the case in the operative and post-operative notes. Debriefing of the patient is done once the patient become conscious and she is out of anesthesia. So debriefing of the patient, patient's relative, and debriefing of the team is also important. Incident report, as she has told, I will fill up the DATIX form. It is same as the incident report. So incident report is, if any untoward accident happens, you have to fill up the incident form. Duty of candor, you forgot this, Shraddha. Okay, so I will apologize to the patient that this complication has occurred, but I will tell her that this complication has been well managed also. Okay, then I will also inform my seniors regarding feedback. I will do a reflective practice. I will mention this incidence in my e-portfolio, and if it is a very serious incidence, root cause analysis will be initiated. Okay, so here this root cause analysis actually doesn't matter here, but for any retained swab or any major complication, there will be root cause analysis. Okay, only thing, because here consultant was not there and the trainee started the procedure, so whether this initiate root cause analysis or not, it depends. Okay, so this will be all clinical governance management. So this is regarding this post-operative complications station of structure discussion. Now, other two questions which can be asked here is how you can prevent the injury, ureteric injury. So pre-operative checkup, pre-operative workup. So if any adhesions are suspected, because she is a appendicitis, previous appendectomy case with midline incision, correct, paramedian incision. So if there are any adhesions are suspected or any endometriosis cases, you can do MRI or IVU. Also, complete dissection should be done. Okay, if any adhesions are there, Where in case of complex cases, complete dissection should be done and exposure of ureter should be done through a peritoneal incision. Okay, and the ureter should be mobilized. So this is the preoperative this thing. Prevention, again, stenting you can done preoperatively, but it is not it should not be done in all routine cases. So only thing it is there, these are the measures to prevent the ureteric injury preoperatively. And in case if you failure to recognize it intraoperatively, how you can recognize it postoperatively is the patient will complain with flank pain, flank tenderness, any failure to recover. Okay, and then post-operative, the most important thing that you should remember is the CT IVU. Okay, you are going to identify ureteric injury by CT IVU. So this is the thing that you should remember for this post-operative recognition of ureteric injury. And other management option, if it is a minor injury, you can just do stenting. If it is a kinking, you can remove the sutures. Okay, so this is regarding this station. Any doubts regarding this structure discussion? Shraddha, got it? You have done well, only some points you forgot.
Yeah, thank you, Dr. Mrudula, so much. Thank you for
Yeah.
giving the opportunity and bringing
No,
back
no
my
problem. Yeah.
shortcomings. Thank you so much.
So this is regarding this thing. Now Dr. Jyoti will take over. She will tell you regarding the history template and she will also take one station. Before that, I will just like to tell you regarding our courses. So we will be starting our new batch for this part 3 exam, which is going to happen in 2021. We don't know, but most probably in the May. So we will start in the January. We will do 4 months course. All 14 modules will be covered. Each module we will take 12 stations. All difficult station, all clinical governance stations will be covered. We will give you domain-wise feedback. At the end, nearer to your exam, we will give one mock circuit free, and we will keep one special telegram group for discussion. So any interested people can call us. Okay, so now over to Jyoti for next thing. So just 1 minute.
Yeah.
We'll make you presenter.
Dr. Mrudula, make me presenter with the Jyoti Milin 1 with that number.
Jyoti Milin 1. Okay, 1 minute.
Yeah.
I will do it. Oh, sorry. Yeah, Jyoti, it's over to you. Got it?
Yes. Thank you.
Okay.
Hope my screen is visible and my voice is clear, friends.
Yes, you are clear. You are audible. Screen is also visible.
Yes, thank you. So first of all, again, I congratulate all the people who have cleared the MRCOG part 2 and you have made a very difficult task very successful in your part MRCOG journey, right? And thank you, Dr. Mrudula, for such a wonderful and detailed session. It gives you all the idea how you will move ahead with the preparation, right? So we passed MRCOG in January, and we skipped one attempt that because we wanted to have a good time for the preparation, and we appeared in November. So friends, as Dr. Mrudula said, no, even though it was a long time, but almost we were in a regular touch with this practice sessions. Okay, so this also I like to advise you, even if when the exam is there, it is still not very much confirmed, but at least one station a day with your friends, with your husband, or with your kids you can do. Okay, and that will keep your interest, right? Yeah, so today I'll be covering this basic history template, and which is very important for the not only for the patient simulated task, but also for the structure discussion, because this is the template which you keep in mind, and most of the time you will attempt the first question of structure discussion, that what all information you want. Most of the time that will be the common question for the structure discussion for the given scenario, right? Okay, so let's go. So in any simulated patient task, introduction is important. Okay, so most of the time outside the cubicle, and those paper will also be there inside the cubicle on the table. Okay, there it will be written what is your designation, you are a ST5 senior registrar or consultant, and where you are. Okay, so suppose it an antenatal station, so you are in an antenatal OPD, okay, or in an early pregnancy unit. Okay, so that you have to note down what all the things which you need to do in the 2 minutes, okay, before entering the station. So first thing which you need to know is whether this is a structured discussion or it is a role player station, right? Then second thing is about who you are and where you are, and third important thing is about the patient name. Okay, so these are the three or four important things which you must note in your notebook which they provide. Okay, so first of all, the first point is about the introduction, where you can formulate your sentence by saying, hello, I'm Dr. Jyoti, one of the senior doctor in where you are, okay, in early pregnancy unit today or in a gynae OP today. Okay, and then you confirm the patient name and age. That is also very, very important. Am I audible, Nandita?
Yes, you're audible, Dr. Jyoti.
Yeah, Nandita message that. Yeah, okay. Thank you. Yeah, so once you finish with your own introduction, then you will confirm patient name and age. Okay, and please try to note it down. Okay, because sometimes in the flow of that station, no, you forget the name. Okay, and that becomes really difficult. Which usually used to happen with me also. Okay, and one important thing is, once the patient says that, doctor, I am Sarah, or Sarah Brenner or something like that, how can I call you? Once you ask that, then continue addressing the same patient with the same name. Okay, once you say Mrs. Sarah and then Sarah, don't do that. Okay, so that is very important. So come in introduction, you will introduce yourself, where you are and who you are. Then you will confirm the patient name and age, and how can I address you. Okay, sometimes in an angry patient station, they'll say, call me Mrs. Smith. Okay, so you will address her throughout the station by saying Mrs. Smith. Okay, then comes the next point of the station is about the concern. That means why she is here. Okay, so what you can say, Sarah, I understand that today you are here. What is the purpose of today's visit? Because you have recently undergone the scan and you want to know the report of your scan. Am I right? Okay, so this should be the formulating sentence while addressing her concern. Okay, so you came to know why the patient is here, and you are just reconfirming that. Okay, then comes the agenda. Agenda is nothing but what you are going to do in this 10 minutes. Okay, that is called that is something called as an agenda. Okay, and you need to formulate the agenda. So agenda, it is divided into two parts. It is your agenda and it is patient agenda. That means what are the all the things you are going to address to the patient. Like, I'll be doing the examination, then I'll explain you the report. Okay, and you may ask some question. That is something called as an agenda. Okay, so why patient is here, that is patient agenda. Okay, she wants to know this. Okay, and what you are going to do, that is your agenda. So for example, Sarah, I will explain you the report, but before that, is it okay if I can ask you a few questions? Then I may need to examine you, run some tests, and we'll discuss management plan. At the end, I'll be providing with the patient information leaflet and support group. Okay, so in the same flow, you will go with the station. So you said that you may need to ask some question. That means the information gathering will come first, then examination, then you will explain her report, and then the management plan, and end the station with the support group and patient information leaflet. Okay, so these are the four starting things which you should be very fluent. Okay, as Dr. Mrudula said, it should be at your spinal level. You should not fumble. And believe me, every mentor says that the way you enter the cubicle or with the way you start the station, no, that is a very important to make impression on the role player and even on the examiner. Okay, so you should be very confident while starting your station. Okay, it should not happen that it is a role player station and you are saying that, hello, I'm Dr. Jyoti, one of the candidate. Okay, so please be very attentive and very confident. Okay, while entering the station and starting opening your station. Okay, and then comes the next point in the information gathering or history template is history of present illness. Okay, so history of present illness should always be with the open question, unless and until most of the time in subfertility module we may need to ask some closed questions. Okay, but in otherwise in other stations it should be always a open question. Okay, so can you tell me more about it? That will be an open question. Can you tell me more about your complaint? That will be the open question. Why you need to ask the open question? As Dr. Mrudula has explained, in the role players kit, no, they have written everything and they don't want to waste your time. They are there to help us. Okay, if you ask close question, since when you are having this, any associated aggravating factor or relieving factor, where is exactly pain, you are wasting your time. Okay, you are wasting your time. So that's why please start with the open question. That is very important. What all the information in her script, no, that will definitely role player will give you. Okay, the very important thing apart from this, whenever the role player is talking, listen to her very attentively, little bit lean forward. You should be not only the good doctor, or you should not have only good knowledge, but you should be a good actor in at least in a role player stations. Okay, so that's what you need to do, as if you are really seeing the patient in your own clinic. Okay, so lean forward, listen carefully, in between acknowledge, okay, is that so? So acknowledge that. Okay, and whatever important point she is telling, you can, with the role players permission, you can ask, can I jot down the important points which you are giving me? But you need to ask the permission. Otherwise it should not happen that role player is talking to you and you are writing in your notes. Okay, so that should not happen. Okay, if you are easily able to remember what the role player has said, then need not do that. Okay, then that's why the thing was open question. Open question is very important. Okay, once you finish with the history of present illness, and another important point in the history of present illness, apart from the open question, history of present illness is basically for you to gain the more information with the chief complaint, and also to for your differential diagnosis. Okay, suppose the patient is coming with the lump through the vagina or swelling from down below. Okay, you want to know whether it is a prolapse, whether it is a Bartholin cyst. Okay, so you need to ask some close question to come to a certain differential diagnosis. So you need to use history of present illness for that also. Okay, so keep that thing in mind. History of present illness, you need to ask few important targeted questions so that you will be able to come to a certain diagnosis. Okay, then then comes the obstetric history. So if it is an obs case, yes, obstetric history comes first. If it is a gynae case, gynae history comes first. So in the obstetric history, you can ask, have you been pregnant before? Can you tell me more about your pregnancy? So see, this is again an open question. If any significant past history, past obstetric history she has, she will definitely tell you. Okay, and if she doesn't give and it is relevant to your task, then please you need to ask. Okay, most of the time role player will not hide any information. Okay, then comes the gynae history. Okay, so gynae history, almost three or four points. One is about the menstrual history, or you will ask her about her cycles, were they regular, any problem, any flow and this thing. Then you need to ask her about her last menstrual period day. Okay, LMP, whether she uses any contraception. And other important thing is smear is only for the lady who is more than 25 years or 25 years or more than 25 years. Okay, don't ask that same question for the 18-year girl. Okay, so you need to have that presence of mind, right? Then contraception history is also very important in very other important stations, like yes, any what do you say, sexual and reproductive health station, even in the ectopic pregnancy, all those things, contraception history is very important. Then comes the medical history. Okay, so for again the medical history, you can ask the just open question, do you attend your GP for any medical reasons? Okay, don't ask, do you have you got any thyroid disease, diabetic, hypertension? It will just waste your time. And information gathering is a task which you need to finish maximum 4 minutes. Okay, maximum 4 minutes. If you ask close question, no, you will waste your time. Okay, role player has to talk what is there in the role player script. Okay, you can't say role player can talk less. Okay, you need to formulate your questions so concisely that you will get all the answer, and it should be like what you will be able to extract all the information. Okay, so for the medical history, you can ask, do you attend your GP for any medical reason or for any medical concern? That you can ask. Okay, then comes the surgical history. So in the surgical history, You will ask, have you got any surgeries done on your tummy or down below? Again, not to use the medical jargon, okay, as Dr. Mrudula has explained. On your tummy or down below in the past. And if she gives any history of any surgeries in the past, okay, suppose appendectomy, please do ask how was the recovery after that. Okay, please do ask this question, you need to keep in mind. Then comes the history of family history. Okay, so Sarah, would you like to share any important family history of any disease that runs in your family, any history of concerns in your family? Okay, genetic disease, the any depression history, okay, that in that cases family history is very important. Okay, then comes the social history. In the social history, what she does for the living, specifically domestic violence cases and other cases also, it is very important what she does for the living. What do you do for living, Sarah? This is your social history. And how is support at home? Okay, that is also very important. Then again, the mental health is a big issue in the UK. So mental health history is very important. So how you can ask a question related to that? Have you ever felt low, depressed in mood, or lost interest in the things which you used to enjoy previously? Okay, so this will be the screening question for to rule out the mental her any problem with her mental health. Okay, coming to the even in the social history, before that, once you finish with the social history, please do ask about the history of any addictions also. Okay, most of the time, no, see friends, it is again the variation in the opinion. For the UK people, it is fine if you ask them whether do you smoke, use alcohol, or use any recreational drug. Okay, so some people mentors do say that signpost and ask, some say you can straight away ask. We always ask straight away and nobody feel offended. Okay, so you can also do that. And if you want to ask in intimate history regarding the sexual intercourse and this thing, those questions you need to signpost and then ask. I want to ask you some personal question. Is it okay if you can ask you and then go ahead? Okay, always signpost. The other important part of the information gathering is drug allergy. And once she says, yes, doctor, I'm allergic to penicillin. Okay, to what extent? And please say that I'll document in my notes. Okay, then BMI, it is an height and weight ratio. Okay, do you know about your height and weight ratio? Do ask about the blood group. Okay, and also do ask about the any concern she has regarding the blood transfusion. And at the last, if you have time, if you feel that you have completed your information gathering within 4 or 4.5 minutes, you can just summarize the positive points which she has given you in the history, and ask in the end, do you want to add anything to it? Okay, so this is the history template. Okay, this is the history, the way you take. And then the next part comes is about the examination, right? And which will vary depending upon the case to case. Okay, any question in this? This was a very basic knowledge, and you should be very fluent. Okay, very fluent. You should practice this information gathering 3 times a day. Okay, so you will save your lot of time out of that 10 minutes if you are fluent with the your history taking. Otherwise you will think and then you will ask, you may lose some time. Okay, so this is very important. Any question in the history template? Yeah.
Hello.
Yeah.
Just I wanted to ask, suppose those any medical history were okay. So for all station we'll ask simply open question. Do you have any medical problem, or are you following your GPO for a medical? And that's enough. Because suppose some station will be there, na, they will be expecting this thing should be asked. So should we specify? Do you have, like, suppose Marfan syndrome? Do you have any hypertension? Anything should we specify?
No, for the general this thing, it is not necessary, Madhu. It is not necessary. Okay, suppose if any specific this thing, suppose you have got any patient with a premature ovarian insufficiency. Okay, there to show your knowledge to your examiner, you can ask, have you got any history of diabetes, any thyroid disease? Because then the examiner will also get the impression that yes, she is asking because this is an autoimmune and this is, so it varies. Okay, it varies. But for the general this thing, you can ask an open question, with a simple question, madam.
Okay, thank you.
Yeah, right.
Yeah.
Okay, thank you.
Thank you so much.
Yeah, so shall we move to the station?
Yeah.
Yeah, who will do? volunteer? Any new people? I can see some name with the Anshika, Asima Khan. Lata, are you there?
Yeah.
Lata, Shagusta,
I can try.
Asima, you will try?
Yeah. But I'm not sure how much I will do because this is, I mean, for the first time I'm going through this.
No worries. Everyone does it. Sometimes it does for the first time. Don't worry, Asima. Okay. So, yeah. Asima, this is the first time you are trying?
Yeah.
Okay. When did you cleared your part 2, dear?
Just recently only.
Yeah, good, congratulations. So this is a bit difficult station. I'm not scaring you, but please do attempt. Okay, please do attempt. And to give a clue, before only I'll tell you, this is a domestic violence station. Okay, very important, as Dr. Mrudula has explained, you know, for the few stations you will have the lay examiner. Okay, so this is a very important station where the lay examiner mostly will be there to judge your communication skills. Okay.
Okay.
Okay, so I'm starting your 2 minutes. Just give me a second. Yeah.
I don't have pen. Do I need to take a pen or copy?
Your wish, if you can remember. Shall I start your 2 minutes? I'm starting your 2 minutes, dear Asima.
Yeah, okay, fine.
You have few more slides also. Okay, after these slides also, you have other slides also.
But the slide hasn't changed.
Shall I change? You have read the first slide?
There's no slide hasn't changed.
No, you have read the first slide, task 1.
Yeah.
Yeah, read that
Yeah.
slide. Read that slide, dear. Once you finish reading first slide, I'll change.
Okay.
After this, Asima, you have one more slide.
Okay.
Once you finish reading this slide, let me know, Asima.
Okay.
Yeah, shall I?
Yeah.
This is the last slide.
Okay.
If you want to see first and second slide, let me know. I can show you. Previous. Your 2 minutes are done. Asima, your 2 minutes are done. Shall I set your 10 minutes?
Yeah.
Okay, fine. No. Yeah,
Shall we
Asima,
start?
please start here.
Yeah. I'm Dr. Asima, one of the doctor in the antenatal clinic today. May I know your name and age, please?
Hello, doctor. I'm Sarah Brenner and I'm 35 years old.
Thank you, Sarah. I understand from your GP referral letter that you are here for experiencing some abdominal pain. Am I right?
Yes, doctor. I'm bothered with just tummy pain, doctor. Just really bothering me.
Sarah,
can you explain this pain a little more for me?
Yeah, doctor. Doctor, I have been bothered with this pain since last 1 or 2 months, and I don't know. Even the GP has prescribed me some medicines, but I'm not getting any relief with that, doctor. I don't know.
Okay. Now, before discussing further, I would like to tell you that I need to ask few more questions to few more questions so that we can make a better management plan for you, and I need to examine you in presence of a chaperone, and I may have to at the end I will write back to your GP. Is that okay?
Yeah, doctor.
Sarah, you have this abdominal pain for the last 2 visits. Since the is there any history of bleeding?
No, doctor.
Can you tell me more about this pain? Whether this pain is continuous, or how does this pain happen? When does this pain happen?
Doctor, it is nothing like that. It will be constantly there, doctor. Here, down below, and even at the back side also, doctor.
Sarah, whom you are staying with?
Doctor, I stay with my husband and my kids.
Is he supportive?
Yeah, doctor.
Are you working, Sarah?
No, doctor, I will be at home. Go ahead, Asima. Complete your information.
Is there any history of trauma in the recent past?
No, doctor.
Domestic violence? I don't understand.
At least complete your information, Catherine.
This is your first pregnancy, right? It's not.
No, doctor. I have 3 more kids.
Can you tell me more about your previous pregnancies?
They were normal, doctor. I had vaginal delivery, and my youngest son, he is just 2 years old.
Okay. What about your periods?
They were regular, doctor, before this pregnancy.
Okay. And do you have any drug allergy?
No.
Are you allergic to any food?
No.
Do you have any history of any surgery on your tummy or down below?
No, doctor.
Is there anything else that you want to tell me?
No, doctor. I'm not able to understand why I'm getting these pains. I've been bothered with these pains, doctor. What shall I do?
Sarah, do you feel safe at home?
Yeah, doctor.
You can tell me whatever we are discussing, this all will be confidential. So you don't need to worry about anything. If there is anything, you can just tell me.
Doctor, I don't know what has happened to my husband, doctor. Since last 6 months, his behavior has changed completely. I know he has a lot of stress at work, but he should not blame me. No, he feel I'm incompetent at everything. I'm not able to take care of my kids. I'm not doing anything. He always blames me, doctor.
Sarah, uh, I'm so sorry to hear all this, and definitely you don't deserve this. But has he ever physically assaulted you?
He does that, doctor.
Okay. Um, um,
I feel
do, do you
really scared, doctor, and I can't say anything against him.
okay? Do you feel safe at home along with your kids? Does
For
he
my
beat?
kids, for my kids, he is fine, doctor. He treats them well, but I don't know what has happened. He doesn't behave good with me.
Sarah, you don't need to worry. We have many social support groups which can be of help to you. And if you are willing, we can escalate this domestic violence as a domestic violence. Have you heard about this? Because
No, doctor.
many
No.
people in UK who are undergoing this domestic abuse, they have a right for their safety, and there are many social groups. I can provide you the information regarding the social groups which can take care of your safety, and further things can be managed by them also. And regarding your investigation, this you have done a scan which is normal, so there is no need to worry about the baby. And do you have any other concerns?
Doctor, how can you help me? Can I get any numbers or help from anybody?
Sorry, can you repeat?
Doctor, how can you help me? Can I get any numbers whom I can contact and I can ask for help?
Yes,
Is there any
yes,
person who can help me?
yes, Sarah. I will give you the number where you can ask for help, and they will be providing an immediate help. They can take you to a safe place where you feel secure until
But
all gets resolved. And
but doctor, I feel if John comes to know all these things, no, he will feel offended and again he will trouble me.
Sarah, you don't need to worry about this, because once we escalate to social support groups, and we can inform the police also if you are willing, and you will be taken good care of. You don't need to get scared of your husband, and you will have a complete you will be under protection.
Yeah, time is done, dear. Okay, you want to close the station? You want to say at the end anything?
I don't know. I think
Well done. Yeah, well done. I know it is a difficult station. I thought that a mixed crowd will be there. No, even new people and old people will be there. No, so they should not feel bored. So I thought I'll take this domestic. But very good attempt, Asima. I can't believe you are doing this for first time. I was just wondering how come you know about so many things. If
Thank you
someone
so
had
much.
asked me to
But I
do this
was stuck
station,
in between.
No, I'm not doing karke. But you had really, I'm really amazed that so many, as a first attempter, you have come up with so many questions. Really well, dear. Very good.
Thank you so much.
Okay, and keep doing this. Okay, believe in yourself and keep doing this. See, you just with the flow, you go went in the station and you performed. Okay, even if some out of the blue some station come, no, just go and complete your information gathering examination. Even if you don't know applied clinical knowledge part. Okay, so at least those mark information gathering tasks and those communication with the patient, those marks you can get. Okay, so not to worry even if any difficult station comes. Okay, fine. So before going into the detailed feedback of the station, I want to appreciate very was some of the very good points of yours. Okay, so introduction was perfect. Most of the most of the candidates uh, don't realize that this is a case referred by GP, but you mentioned that. I'm very happy. Okay, and even you asked, we started with the open question. That was also fine. In the history of present illness, you started looking for the differential diagnosis. You asked me for the bleeding, you asked me for the trauma. Okay, that was absolutely fine. Knowing that it's a domestic violence station, you asked me for the social history. Yes, that was perfect. Even the obstetric history was perfect. Yeah, you asked me about the allergy. You asked me about the surgery history. That's fine. And at the end, when I come up, you asked me about this domestic violence. No, very good. You said that things will be confidential. It is. That's why I said I amazed with the way you performed as a first performer. Okay, so really well, dear. Okay, then coming to the detailed feedback of the station. So as all of you are aware that this is a very important station, especially from the communication with the patient gathering part. Okay, how you deal with the patient, how you react with the patient's emotions, all these things now are very important. Okay, so once you enter the station, most of the time you will realize that this is a domestic violence station. One of the important thing which we realized during preparation is, please don't be under an impression that this domestic violence station can come only in a ops part. Okay, it can come in a gynae cases also. The patient has bothered with the repeated pains. Okay, so please keep that thing in also mind. Domestic violence station can come as a patient presenting with some gynae complaint. Okay, that is a very important point. So, and before entering the station, you may realize that this is a domestic violence station and you will be able to do that. Okay, but there will be some clues, even if it is not very much clear, there will be some clues which role player will be always giving you. Okay, she will be talking in a very low tone. Okay, she's not looking at you, she's like very not responding to you, this thing. Otherwise she will say, I'm in a hurry, doctor, is it done? Okay, so she is not attentive. So these are all the things which can point that it could be a domestic violence station, right? Okay, then once you enter the station, so you know that this is a domestic, or you guess that it is a domestic violence station. Your tone of the voice should match with the patient voice. Okay, you don't be over enthusiastic. Okay, so your voice should be also calm. Okay, so hello, I'm Dr. Asima, one of the senior doctor in antenatal clinic today. May I confirm your name and age, please? Okay, so she will, how can I call you? She will respond. Then comes the Sarah, as we have seen, Asima, as we have seen in our information gathering template, once you address the concern, what comes the next is concern. So Sarah, I can see that you have been bothered with the tummy pains since last few days, and also you have undergone some investigation. So you are here to know more about that, and also to know more about your pains. Okay, so this becomes the concern. Don't use abdominal pain. Abdomen is a medical jargon. Okay, so I will say tummy pain. Okay, you finish with that, this initial part. Then comes the agenda of the station. So Sarah, definitely I'll address your concern, but before that I need to ask you few questions just to know you better. Is it okay? I may need to examine you in the presence of the chaperone, and at the end we'll discuss about your management. Is it okay? This comes the agenda, and then comes the history of present illness. So in the history of present illness, Asima, again with the open question. Yeah, so Sarah, can you tell me more about your pain? tummy pain, and she will give you vague answers. Okay, so taking information gathering is also very important to establish a rapport with the patient. Okay, because the domestic violence, no role player will from the starting point only will not cry or will not tell you that I'm in trouble with my husband. Okay, so you need to establish the rapport. The role player should have must get that trust on you. Okay, so for that also information gathering will help. The way you speak, okay, that will also help. Okay, so in the history of present illness, once she tells you what she has been bothered and whatever information she gives you, you need to do some differential diagnosis. So any problem with the water work, any history of bleeding, any history from discharge from down below. Okay, these are the few differential diagnoses which you need to ask. Any aggravating relieving factor you need to ask in the history of present illness. Once you finish with the history of present illness, what comes next is about the obstetric history. Okay, so Sarah, have you been pregnant before? See, Asima, this is in she is a multipara lady. Okay, with three kids, and this is a fourth pregnancy. Okay, you can signpost and ask, Sarah, some of my question may you feel private, but if you allow me, it will help you. It will help me to giving you better management plan. So may I ask you, all these kids are from the same partner? Because these things, no, the issues in the relation, and those can also be an aggravating factor for the domestic violence. Okay, are they from the same partner? But please do signpost and then ask. Okay, and in a gentle voice. Okay, as if we ask some private question to in our OPD to some patient. Okay, in the same, exactly the same way. Okay, and she told you she had a multiparallel. So ask about the deliveries the way you asked. Okay, that's fine. Then comes the menstrual history. So when she had her last menstrual period, whether she used any contraception, and in this pregnancy, Asima, it is very important to ask also about whether it is a planned pregnancy or unplanned pregnancy, right? Maybe because of the sexual abuse and this thing, she has got the pregnant. Okay, so unplanned pregnancy may point you towards the your maybe a plus point for your domestic violence dealing. Okay, so that is the thing. Then comes the past medical history. So complete it. Okay, you ask past surgical history may not be existing. Why I'm asking you to ask the inquire about the past medical history? See, there could be one more differential diagnosis for this type of the station is about the case of the depression. Okay, so in that also you need to ask rule out the history of past medication she is taking. Okay, so that's why past medical history. If she is suffering from chronic debilitating disease also, that may lead to depression. Okay, so that's why you need to ask medical history. Surgical history may not be that important. If you don't have time, you can skip on it. Okay, then comes the family history. Family history is again important because again you need to differentiate between whether it is a really domestic violence or it is a depression case, right? And then comes the social history. So social history is the first opportunity for you, Asima, to make the patient to talk about her domestic violence. Okay, so what do you do for a living, Sarah? So she will say whatever. Does your husband supports you? And she will definitely, because that is their acting, they need to do. Okay, so she will definitely little bit hesitate and this thing. So this is the first opportunity for you to make her talk about her domestic violence, but she will not directly say that I'm suffering from the domestic violence. You need to convince her that you can trust me, you can trust Asima. Okay, so Sarah, let me tell you that Sarah, in UK, about 1 in 4 women suffers from something which we call as in domestic abuse, and this is a very common condition. Okay, whatever, Sarah, we are going to discuss will be completely confidential, and any woman suffering from the domestic violence has help available at every steps. Okay, every step. So these are the assuring words of of yours which will make her comfortable, and she will come up with her uh, that issue. Okay, and then she may start crying and this thing. Okay, so this is the first opportunity. Okay, suppose if she doesn't come up with this issue here, you have one more opportunity. I'll tell you in the explanation. So you have come to the social history. Then what your husband does he supports you well? Okay, then take the mental health history, take the history of drug addiction, allergy, blood group also you need to ask. Okay, and and you finish and ask her whether she wants to add anything. Most of the time in the station there will be an on examination, they will give you something clue that midwife has noticed some bruises on her thigh or abdomen somewhere. Okay, so the next opportunity for you to make the role player talk is about the when you do the examination. Okay, so Sarah, if you allow me, I want to do I want to examine you in the presence of chaperone. Is it okay for you? Okay, and once you do that, okay, you will not do examination as such, but you will have the finding. So Sarah, what I can understand after talking to you and after examining you, that your baby is doing well. Really, your baby is also doing well. But Sarah, I have noticed that there are some bruises on your on your thighs. So could you please tell me what it is, how this has happened? So again, she may little bit hesitate for opening her issue. Okay, again reassure her. Okay, saying that confidentiality, 1 in 4 women suffer from that, and help is available. Nobody will not disclose to anybody without your permission. So these are the 3 or 4 points you need to talk here, and then definitely she will open up. Okay, so once she starts the crying and this thing, this thing, so you don't say anything. Okay, just listen to her, let her cry. Okay, and there will be a glass of water or tissues on your table, so you have to just pass those tissues or glass of water to the patient. Okay, so this is the thing which you don't stop her in between. So once she finished crying, her acting, so you can ask Sarah, I'm really sorry to hear all this. So first of all, Sarah, is it okay, are you comfortable to continue with the consultation, or shall I make an extra appointment? Okay, so this is the way you take the patient into consideration. Then she will obviously say continue, so continue. Okay, so once you know that this is once you have confirmed that this is a domestic violence station, what you are going to do next is the quantification of the domestic violence, something called as a quantification of the domestic violence. So first thing in the quantification is, Sarah, is it an only physical he hits you, or does he does he verbally abuse you, or also he hits you? Okay, does any history of it, does he force you for the sex? Okay, so sexual abuse, physical abuse, those also. How is his behavior towards the kids? Okay, whether the children are also involved. Okay, that also. And then, does he bear any weapon? Does he threatens you that he will kill you? Okay, so these are the 3 or 4 questions you need to ask to quantify the severity of the domestic violence. Okay, so these are the things which will for which she will give you answers. Okay, then once you quantify the domestic violence, the next thing comes in the station is about you need to give her some plan. Okay, now you have to talk her how you can help her. Okay, the first question which you need to ask is, Sarah, do you feel safe at home? This is the very important thing. Otherwise, if she is not feeling safe at home, she is feeling that there is threat to her life, you need to admit the patient. Okay, so she will say that my husband may not like if I stay at a hospital and this thing. So you can say that, Sarah, if you don't feel to go feel safe to go home, then what we can do is I can admit you, and I can tell your husband that you have been admitted for the evaluation of your tummy pain. Okay, and meanwhile I can arrange help for you. Okay, we can arrange help for you. Okay, suppose she feels safe to go home. Okay, so then you have to equip with some strong things that whenever the risk comes, she should be safe. Okay, so you have to equip her some important things. Okay, so what you can do, Sarah, if you feel safe to go home, then I'll be providing you with some important number. Okay, one is the women's aid, then one is the other is the police number, that is 999, and then safeguarding services and specialized domestic violence midwife will be there. Okay, so all these people's numbers you will provide her. Okay, you will provide her to this role player, and you will say that, Sarah, keep all this number very safe, so that your husband will not come to know about this number. Okay, so she can just keep in a purse which will be there, handbag which will be there with her always, or in a lip balm cap. Okay, so there she need to put it. Okay, then apart from that, you need to provide her an escape plan. Escape plan means whenever she feels any threat to the her life, she need to escape. Okay, so that is called as an escape plan. Okay, so Sarah, whenever you feel that, okay, whenever you feel that there is a risk to your life, okay, you need to have your escape plan. So Sarah, before that, can you tell me that have you shared this thing with any of your relative or your friends? Okay, so if she has shared or whatever she is respond, okay, tell her that, Sarah, please keep your all important documents like passport, accounts, account books, and ATM cards, car keys. Okay, all these important document along with your pair of clothes to the person whom you can trust. Okay, so that if necessary, if you have to run from the your home, you can do that. Okay, so this is something called as domestic violence and sorry, the escape plan. Okay, and the numbers, whenever you feel any threat, please immediately call them. The immediate help will be available. Okay, immediate help will be available. So this is the way you have to put your domestic violence management plan. Then the last thing, it is once you give all this information, okay, so she will tell you, so doctor, I'll feel yes, I can go home, otherwise I don't want to go home. All these things you will tell. Now for you, it is the time to end the station. Okay, so before ending the station, there are few important things which you need to do in this station. Okay, so Sarah, if you still have any pains, I can fix an appointment with my consultant, or I can refer you to the pain management clinic. Sarah, apart from me, if you want to speak with anybody else, I can arrange an appointment with our counselor colleagues. Okay, they can also help you. Okay, so this is the second thing. Okay, number you have already provided, the important number. Okay, and the support group, domestic violence midwife number also you have given. Give her some patient information leaflet which will have all this information, and also talk about the support group. Okay, if you don't know the number, doesn't matter, you can just say the support group. I can share with you some web links of support group which will help you, okay, to come out of this situation. Before ending the station, okay, before ending the station, please say thank you, okay, to her, because she has shared such an important and sensitive issue of her life with you. So Sarah, thank you so much for sharing such an important issue, such an sensitive issue with me. Okay, please don't worry, I'm there always to help you. Okay, and then you can say thank you and close the station. Okay, so this is the way you do your domestic violence station. Is it clear, Asima? Mode
Yes,
of
yes,
communication.
yes. Thank you so
Yeah,
much.
yeah. Welcome, dear. Any question in this? If I missed on anything, okay. So it should be very clear at the end of the consultation. Role player should be equipped with something. It should not be his. Have this thing. Like, I'll give you this number and I'll give you that number. Okay, she should feel equipped. Ki mere paas, I have that number and I have escape plan ready. Okay, support group, all those things. Okay, so you need to finish with that. Any question in this? Anybody? Any other candidates? Yeah,
Dr.
yeah, yeah.
Jyoti, can you
Yes,
please
yes,
share the slides of the key?
yes, yes. I'll share. I'll share. You want to see now, or you want me to put it in a group? See, the session will be uploaded in the YouTube channel also, our YouTube channel. Okay.
Okay, thank you, Dr. Jyoti.
Yeah.
I have one question. Do we have to ask everyone the reservation of blood transfusion, or only selected those who are for operation or like that?
See, again, I will not say that for every patient you need to ask the Jehovah's Witness, but sometimes, no, for the safety thing, I used to ask Nandita, because sometimes it is an hidden this thing also. Okay, so suddenly the patient come up with the doctor, I have some this thing. So better to be on safe side. Two words will not matter much. I used to ask.
Okay.
Yeah.
Okay, thank you.
Yeah. Yeah. Apart from this, anything else?
Very nice station, Dr. Mrudula and
Thank
Dr.
you,
Jyoti.
Shraddha. Thank you.
Excellent.
Thank you.
And it was
Thank you so
great
much.
revising thing for us also. Every
Yeah.
time we learn something from the mentors. Thank you so much.
Because of all your support and all your involvement, no, we are able to do this. Okay, so anything, and we have our group on of part 3 intense preparation. Any question, any queries, any help, okay, you can post on the group. We can help, and we'll in a short time, no, we will start some free activity also we can do on the group. Okay. Yeah. Okay, it was really nice to meet you all. Some old friends like Surbhi, Rani, all this Madhu. So they were there with her. sessions. Yeah. Okay. Thank you so much.
Thank you. Thank you
So
so
shall
much.
we
Thank you,
end the
Jyoti.
session? Thank you. Thank you.
Thank you all of you for attending this session. I think you should start your preparation. Those who are newly passed, please start your preparation slowly and steadily. Listen to the videos. And then next thing, please be active on the group. We will start our free activities soon in the group. Daily free activities, we will do something. Okay. Yes, the Telegram link is there above in the group, in this chat box. Okay, you can see that link. Yes, we will upload the video in the YouTube, our YouTube channel. And please start preparing. Don't get this thing that when will be the exam. There is no need to start preparation from now. It's not like that. Just we have to start our thing. We have to do our part. Let the RCOG do its part. Okay. So definitely the exam is going to happen. We don't know when it is, but mostly it will be in the May, and I think everyone will be getting this thing. Okay, just 1 minute. I will send you the group link. 1 minute. Oh, sorry.
Dr. Mrudula, what is happening in our group? When we are going to start?
Dr. Rani,
I
you
have
have
already
not
asked in our,
responded. Yeah.
we have already asked you all people when we should start. Okay, we are ready to start
I'm
anytime.
ready.
Okay?
I'm ready. I'm ready.
Okay, so we will start. We will start in soon, next 1 or 2 weeks. Okay, no problem.
Okay.
Okay.
Okay. Thank you.
Yeah. Yes. Okay. Okay then. Jyoti, can you please send the link in this chat box again? I'm not able to copy it and again send it in the chat box.
1 second. Just hold
Somebody.
on, friends. Yeah, I'll do.
So thank you all of you. Yes. Dr. Oluwa Funimola. Sorry, I can't pronounce your name. But yes, see the link is there. Okay, you can join with that link. Yeah, we have already shared, but yes, again I will share it in the Asima, we will share it in the group also. Part 2 group, we will share it again. Okay, so that you can join. Okay, then bye for now. We will meet regularly. Hope we will meet regularly for the sessions. Okay, bye. Bye all of you.
Thank you, Dr. Mrudula and Dr. Jyoti. Nice to hear your voice after a long time. Thank you very much.
Yes, thank you, Salma.
Thank
We are
you.
also happy to hear your voice. Okay, yeah, bye.
Yeah. Bye.